ऑप्शंस तो दिख रहे हैं ना, सिर्फ इमेज को जूम करो, सिर्फ इमेजेस को जूम करो. शिप्रा का नहीं पता. क्विज बनाया. एकच दोन्ही वापरू वो बोल रहे पोडियम का दोनों माइक
हाँ ठीक है, तो कर बंद कर रख दे फिर बात कर।
छोड़ो वरना मैं अपना ही नहीं दिखा। हेलो।
Behind every chart, every diagnosis, and every clinical trial is a human life awaiting a miracle. We often say medicine is a science of uncertainty and an art of probability. However, today we focus on the one constant, our unwavering commitment to excellence.
A very good morning and a warm welcome to our respected dignitaries, faculty members, judges, guest speakers, participants, and my dear fellow students. We are delighted to have you with us today for the day 2 of Zenith, a summit to excellence.
I am Zeel Jain, and alongside my co anchor Aditya Kumhar, I have the privilege of guiding you through today's thoughtfully curated program.
Reflecting on day 1, we did more than just attend sessions. We ignited a dialogue from the intellectual rigor of the debates and symposium to the visionary perspectives offered by our speakers. The atmosphere was charged with the palpable hunger for knowledge. We witnessed mentors and students bridging the gap between theoretical medicine and bedside practice.
If yesterday was about laying the foundation, today is about scaling the peak. We are moving from the what and the how of medicine to the why, the very heart of our clinical practice. With insightful sessions, intellectually stimulating competitions, and meaningful conversations ahead, today promises to be both enlightening and inspiring.
To our delegates, bring that same curiosity, fire, and precision you demonstrated yesterday. The bar has been set high, and we know this audience is ready to surpass it. Without any further ado, let's us set the wheels of day 2 in motion. I would like to request everyone to stand for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा। विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा। तव शुभ नामे जागे तब शुभ आशीष मांगे। गाहे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता। जय हे जय हे जय हे जय 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 हे।
भेजा है लिंक देखो भेजा फॉरवर्ड मार भेजा है लिंक वहाँ पे से फॉर्म कॉपी भेजने बोल रहा है। हेलो हाँ मैम लिंक भेजा आपको लिंक भेजा क्यों मुझे फॉरवर्ड कर तेरे को भी देख रही है मुझे फॉरवर्ड कर भेजा हाँ मुझे फॉरवर्ड करो तो मैम को भेजना कि मान को भेजता हूँ फॉरवर्ड स्टार्ट तो मेरी करना अभी इन्हीं का इंट्रो है ना डायरेक्ट भेज दिया तेरे को भी सबको भेज मैम को नहीं दिखने वाला ये अनम्यूट रखो ना फिर तुम लोग मैम को सुनाई देना चाहिए ना। हाँ बेटर है। अरे शिवम दास क्यों वेटिंग एंटर कर रहे।
Hello. Hello.
Yes, ma'am, we can hear you.
Right, that's perfect. Good.
It is my distinct honor to introduce our first speaker for the day, Dr. Priyanka Jani ma'am, an esteemed alumni of Rajiv Gandhi Medical College. We are privileged to have her with us today as she breaks down the fascinating world of orthopedics from bone to breakthrough and everything in between.
Ma'am is a distinguished UK trained orthopedic and spine surgeon. Her academic journey is marked by excellence, holding an MBBS, MRCS, and an FRCS in trauma and orthopedics. She completed the prestigious London Stanmore training rotation and further honed her expertise through elite fellowships, including the National Spinal TIG and Stanmore Advanced Spinal Deformity Fellowship.
Specializing in adult spinal deformity, complex degenerative disorder, and cutting-edge endoscopic surgery, ma'am is as much as leader as she is a clinician. A graduate of NHS Leadership Academy and an Bow Future Leader, she currently serves on an executive committee of both the British Association of Spinal Surgeons and British Scoliosis Society.
We are truly privileged to have such a visionary with us today. Although she is joining us virtually, her expertise and presence will be felt across this hall. Please join me in welcoming Dr. Priyanka Jani ma'am with a huge round of applause.
Hi, good morning. Thank you so much for those kind words, and thank you very, very much for this opportunity. Honestly, it means a lot. I'm not sure whether you're able to hear me, but I'd need some help to be able to share my screen because currently that's disabled.
Ma'am, you're on mute. ये change करा है इसमें.
Hello, can you hear me now?
Yes, ma'am, we can hear you.
Perfect. Thank you.
पहले वाला
Okay.
ठीक था.
Again, thank you for this opportunity, for allowing me to speak here with all the students of RGMC. It brings back fabulous memories. I'm sure there might be some teachers there. To all of you, good morning, and kindest regards. I want to start by talking about the topic and how I came about choosing it. So, we're going to talk.
Ma'am, just a second. ठीक है यार, आज सब अच्छा चल रहा है. अभी करके really sorry for the interruption, ma'am. You can continue.
Can you hear me?
Yes, ma'am, we can hear you.
Yeah, perfect. Okay. So, like I said, I'm going to talk about orthopedics and breaking bones because obviously breaking boundaries and then everything that lies in between. So, when I was first approached, dare I say, less than a week ago, about talking with all of you, as amazing as that opportunity was, it left me very confused because I sat there thinking, how am I going to talk about a journey that's taken me years in 20 minutes? And then I went, do I even actually have anything to talk to you guys about? Somebody at work very kindly pointed out that if you're struggling to find the perfect topic, Priyanka, find an honest one. So that's what I set about doing. I asked myself 3 questions. What is it that I do? Well, I straighten spines and fix bones. Very simple. What did I have to overcome? A few things, distance primarily, self doubt, and that whole stereotype about, oh, mate, you don't look like an orthopod. And the most important thing was I sort of asked myself what it is that I want you to take away from this. So I've built this talk around 3 acts. The first is talking about breaking bones. The second is talking about breaking boundaries. And the third, and this I believe is the most vital thing, is talking about those little things which, when added up, seem to make the most important and significant difference in our lives. So let's talk about breaking bones first. It's technique, and it's, as much as we don't like to agree, there is compassion and there is some precision involved. But when I talk about breaking bones, this is a picture that comes in front of all of us. And, there is some truth in the matter. We love fixing bones, and, it's important to fix a fracture when we see one. But I think if we stop and thought about it, there is a little bit more finesse to it. It's not just all about trauma and fixing bones. There is a plan to it. There is precision. There's teamwork. Kindness is what brings it all together. And of course, there's a whole lot of fun and adrenaline involved. In the world of spine deformity, we correct straight spines. Simple. But we also bring about a difference in people's lives as a result of our work. And that is very fulfilling. If I can just take a minute and digress and tell you what changed it all for me. When I was a registrar working in spines, I just wanted to do it because it was supposed to be a tick box in my training. But in clinic, we'd met this 13-year-old boy, scoliosis, baggy clothes, had huge sort of image issues and was self-conscious. And mum sort of told us how he'd sort of withdrawn into his shell, didn't take pictures, didn't even engage or look up. 2 days after the operation, when he was stood up in front of the mirror, he holds his phone out to me and says, Priyanka, can you take a picture for me? And that moment, when you realize that what you do makes such a big difference in somebody's life for the future, it's A, very humbling, but B, very satisfying. And I think that is what drew me towards this sort of work. Spinal surgery is very cool, no doubt. The future for what we envisage in surgery is the here and now in spines. Yes, we do the complex, we do the nerves and, deal with spines all the time without batting an eyelid. but the technology is so advanced. We are undertaking endoscopic spine surgery, so small incisions, and we get instrumentation done through sort of less than a centimeter's worth of incisions. There's a robot-assisted surgery, so again, planning, precision, taking the risk of paralysis out of the equation. And for those of you that are the Iron Man and Iron Woman of the future, love playing with Jarvis, we've got that covered as well. We've got mixed reality headsets now that we use, which is very much like our own personalized Jarvis, where we can superimpose the MR and the pre-op CT over a prone patient so that we can actually see all the three things, the patient's anatomy superimposed with the CT and the MR, for us to be able to direct our screws and direct our correction. So the future is here. And for all those people who enjoy anatomy, or probably not, but in the future, I promise you will. So for those people who enjoy anatomy, enjoy problem solving, love innovation, spines is for you. This is the centimeter incision that I was talking about for endoscopic spine surgery, where we undertake spinal decompression for canal stenosis, discectomies. That's a big O-arm. It's a CT machine within the theaters, and we take these live 3D images and then plan our screw trajectory, which is the screen on the side. And that's the Mazor robot, which is mounted on the patient. And the arm is what helps us drive our screws in the pre-planned trajectories, which again is visible on the screen on the side. And this was what I was mentioning, which is the Brain Lab Leap mixed reality headsets that we are currently trialing. So, it's all fancy and it's all fun, but can I just say that all of this is built on the foundation you are laying today within the classrooms in our GMC. So, anatomy, physio, biochemistry, for me, when I was there in your shoes, I don't know, I'll leave it for the teachers to tell you more, but I wasn't the best at these subjects. And I wish I was, and I urge you all to be. So it's more than just the pain of your first year in med school. It is vital for your progress in the future. It's that operating manual that you'll be carrying with you for the rest of your life. So if you want to be the master, you have got to master the basics. There's no shortcut. That brings me to the second act, which is breaking boundaries. It was said that courage is not about absence of fear, but being able to triumph over it. So for me, that courage took me from Thane to London. Same dream, wanted to be a surgeon, just different rules and different arenas. So a few things changed. For me, it was new system, new standards, new accents. Some would call it independence. I call it loneliness. And I learned a new knack, which is learning how to ask for help and being okay with it. Through all of these changes, I'm glad that a few things remained unchanged, and they should. It was my work ethic, my absolute unwavering curiosity for everything orthopedics and spine related, my love for theatre, and faith in the process, where I do believe, hand on heart, if you put in the hard work, it eventually pays. This whole cliche about orthopedics as a woman and spine deformity as a woman, you just have to be a person to do it. It genuinely doesn't matter whether you're a man or a woman. What you need to do is fit the standard and not the stereotype. And the standard is what you set. So people will assume, because, that's what people do. Oh, the job's going to be too demanding. It's too physical. You won't last a day. Not for you, darling. Why don't you do hands? What I learned through all of that noise is preparation beats perception, hands down. Learning to remain calm in the midst of all the negativity, all the assumptions, all the chaos is a superpower. It will hold you in good stead through life. Ergonomics is important. The last two things are most important. I don't want you to take away from this that this has been this amazing journey that I've been on. Absolutely not. I've stumbled through it. And people which I hold as my mentors, have helped me through it. The first mentors that I've come across were my teachers at RGMC. Dr. Banjan, if she's there, big shout out to her. She was my first referee that filled up my reference form for my first ever job in the UK. So thank you, ma'am, again. And it's those mentors that you need because they are the ones who are going to carry you through life. And lastly, be visible, because you, even if you feel you don't matter, or you're too small, too insignificant, you might be that person that might actually A, inspire somebody else, and B, might be the mentor that somebody else was looking for. My last act, everything in between. These are the small things that make, like I said, the biggest difference, I feel. So success is important, but success without peace, I think, is still a failure. Work-life balance, and a lot is being said about it, and I have struggled through it, and I'll give you my real-life version of it. So work-life balance is never 50-50, right? It's 4:30 in the morning, I'm sat here, kids are sleeping, there's no balance. But it's seasonal, You'll have some off days where work takes precedence, but you're going to have some great day where you can put work on the back burner, enjoy with family, enjoy with friends. But it's down to you to get that mix right, okay? There are some non-negotiables. Sleep is paramount. I say that with less than 3 hours of sleep, but sleep is paramount and I'll be catching up tomorrow. Movement is important because as surgeons, our hands, our bodies are our vehicles, and we need to make sure they're well-oiled and well-functioning vehicles. Food is fuel. As much as we love operating and we love working, and we do need the food to nourish us so that we are able to do the work that we want to do. And boundaries are very important. As much as we want to say yes to every project that comes our way, it's draining, and you've got to look after yourself. So you need to set those boundaries. Life lessons. I've had a few years, unfortunately, added under my belt. So I have learned some lessons, and I'm hoping I can share those with you, guys and girls. Enjoy the journey. There's no point saying, I'll get my exam, distinction mil jayega, I'll be happy. Because those goalposts keep moving. And I've seen it myself. I'll be like, I'll get my foundation, yeah, I'll be happy. I'll get my MRCS, I'll be happy. It never ends. So just enjoy the journey and see where it leads you. Comparison, the only person you want to compare yourself to is yourself. You want to make sure you're better today than you were yesterday. So long as you can do that, that's good enough. Think about the 5 people that you hang out with the most. Take the time to think about it very carefully. And I'll tell you why that is. Because you are the sum of those 5 people. So if you are thinking about those 5 people and thinking, oh God, this one's a hassle, oh God, this one doesn't know what he or she's talking about. Well, hate to break it to you, but you are the net of those people. So be careful who you surround yourself with. And if you do have great people around you, cherish them. Lastly, self-love is important. It's not weight, it's discipline. You need to be able to look after yourself, and looking after yourself forms part of that self-love. You can't have it all. No. You absolutely can. And do you know what? You are those very few people who've gone through 12th and entrance and I don't know what else there is now. You've jumped through all those hurdles, and you are the creme de la creme, sitting in a medical school, having a bright future ahead. So you already have it all, so celebrate yourself. For me, my all looks like this. My 2 daughters, spines, which we keep straightening. Me going out with my friends, me at conferences, and everything else. So if I want you to take away something from this talk, it's this. Learn your fundamentals. It is very, very important because it is on this basics that the fancy stuff sits. Choose your specialty that excites you. You don't, if it's whatever it is, you do not need other people's approval for it. If you enjoy it, go ahead and do it. Let your work speak for itself. And make sure you look whilst you're doing that work. Build mentors, build friends, because you're going to need them on this fabulous journey that you're on. Lastly, break bones with precision, break boundaries with courage, and build a life filled with peace. God bless you, and thank you again so much for this opportunity. Thank you.
The insight was truly enlightening. Please give a huge round of applause
Great.
for that masterclass. Thank you, ma'am. We are deeply grateful for your time and for sharing your immense expertise with us today.
It's been a pleasure, guys. Honestly, thank you very, very much for this opportunity. It was hardly a masterclass. It's just things that I wish somebody had told me, or I would tell to my younger self, which is why I'm sat here telling it to you guys. But if ever any of you need any help, or just want to talk, I'm happy for you guys to have my number. Call me, text me. As Himanshu will tell you, I'm not the easiest to get hold of, but I do eventually get back to you. So, happy to help. Pass it forwards.
Thank you, ma'am.
Have a lovely day and enjoy the rest of your function. I'll take your leave.
Yes, ma'am.
Thank you.
Thank you so much for the contribution, and we apologize for the technical glitch at the start of the session. Okay?
Moving forward, we arrive at one of the most intellectually stimulating highlights of this conference, Inferno, the case presentation competition. This is a platform where the brightest of minds gather to showcase their clinical acumen and depth of knowledge.
Indeed, this format goes far beyond sharing unique cases. It encourages vital discussion on differential diagnosis and treatment strategies, fostering a collaborative environment dedicated to elevating patient care.
These presentations emphasize the power of thorough clinical reasoning and evidence-based practice, reflecting both the dedication of the presenters and the advancements shaping the future of medicine. Throughout this competition, we will witness groundbreaking research and explore ideas that challenge conventional boundaries.
It is truly a celebration of the collective pursuit of knowledge and commitment to improving our healthcare system as a whole. Every participant have invested countless hours into refining their work, and we are eager to witness the depth of their insight.
To evaluate such high caliber presentations, we are honored to introduce our esteemed panel of judges. Joining us first is Dr. Jayanarayan Senapati Sir, Professor and Head of Department OBGY.
We are also joined by Dr. Saileja Poddar Ma'am, Professor and Head of Department Pediatrics. We thank you both for lending us your expertise today. I now invite our case presentation head, Ms. Savita Yadav, to commence this competition.
Honorable judges, esteemed faculty members, and my fellow participants, good day to one and all. I am Savita Yadav, the case presentation head, and it gives me immense pride and honor to welcome you all to this academic gathering. It is truly a privilege to stand before you today and host an event that reflects the very essence of clinical medicine: observation, reasoning, and evidence-based decision-making. We sincerely thank our judges for their valuable time and for mentoring and inspiring young medical minds through their insights and evaluations. Before we proceed further, I kindly request your attention to the rules governing this event. 1. Each participant will be allotted a maximum of 7 minutes for presentation, followed by a 3-minute question and answer session with the judges. 2. The identity of the college must not be revealed at any point of time during the presentation. 3. The decision of the judges and the organizing committee shall be final and binding on all participants. Any violation of these rules will result in immediate disqualification. With this, we formally begin Inferno, where every case is a challenge and every mind is a flame of discovery. Let us begin with our first presenter.
Good morning, everyone. I am Tanishi Baheti, and I will be presenting a case on cystic fibrosis. To begin with, what is cystic fibrosis? Cystic fibrosis is not just a simple lung disease. It is a disease that spreads to your whole body. It is a mutation in the CFTR gene that leads to defective chloride ion transport, causing water imbalance and resulting in production of abnormally thick, sticky mucus in your organs, causing cough, respiratory infections, pancreatic insufficiency, and failure to thrive, which all can be seen in the case that I'm about to discuss. To begin with the case, a 3-month-old male, Muslim by religion, first by birth order of a third-degree consanguineous marriage, was brought into the OPD with the chief complaints of cough and cold since 7th day of life, fever since 1 day, difficulty in breathing since 1 day. The baby was apparently all right until the 7th day of life, when he developed cold and cough. The cough was gradual in onset and persistent, occurring in bouts and sometimes followed by post-tussive vomiting. It was associated with whitish nasal discharge, but not with choking or aspiration of feeds. Over the next 2 months, the baby had recurrent intermittent episodes of fever, about 3 to 4 times, which subsided temporarily with medication. One day before admission, the baby developed acute onset of difficulty in breathing, which was gradually progressive and worsened with irritability and crying. It was associated with poor feeding and noticeable weight loss. There was no history of aspiration of feeds, choking or cyanotic spells, no history of seizures, loss of consciousness, or abnormal movements were observed. The patient was not in contact with tuberculosis or any TB patients. A pediatrician at a nearby clinic was consulted at 15 days of his life for cough and difficulty in breathing, lasting 6 days. He was then managed with IV fluids, oxygen support via hood box, and IV antibiotics. Since there was no significant improvement, a CT chest was done which showed patchy consolidation in both of his lungs, suggestive of bilateral pneumonitis. The antenatal, natal, and postnatal history seemed to be non-significant and normal. The baby had attained milestones appropriate for his age. The baby was exclusively breastfed since birth, but the feeding gradually decreased due to cough and respiratory distress, causing weight loss. The stools, which were initially normal, had later become frothy. There was a positive family history observed where the patient's grandfather had died due to similar respiratory illness, suggesting a possible hereditary or familial predisposition. Here is the pedigree chart. The baby was unimmunized since birth. On examination, the baby was examined on the mother's lap after consent. He appeared irritable, cachectic, and with sunken eyes, depressed anterior fontanelle, mottling, and delayed skin turgor. The oral mucosa was dry, indicating mild to moderate hydration status. All the parameters for the anthropometry were below expected for age, indicating failure to thrive. The vitals and subvitals seemed to be normal. On further examination, on examining the respiratory system, on inspection, the baby had increased work of breathing with tachypnea along with subcostal and intercostal retractions. On palpation, the inspectory findings were confirmed. The trachea was central and bilateral chest expansion was reduced. On auscultation, air entry was reduced bilaterally and crepitations were heard on the left side. Other systems seemed to be normal and non-significant. Initial workup began with a chest X-ray which had bilateral heterogeneous opacities, an ABG which showed respiratory alkalosis indicating hyperventilation due to distress, the HRCT thorax where a patchy consolidation was found, 2D echo ruling out congenital heart diseases. The labs of the patient had deranged liver enzymes. At around 20 days of stay, it was seen that due to persistent bouts of cough, non-resolution of bronchopneumonia, reduced air entry on both sides of chest, the child was taken to a pulmonologist at another specialty hospital, where gastric aspirate for gene expert was sent, and it came back negative, ruling out TB. The child that was passing froth-colored stool the stool sample was sent for a Sudan 3 stain, which came back positive, diagnosing it as pancreatic insufficiency. The labs here show that the liver enzymes are deranged. The USG abdopelvis showed hepatomegaly. On high suspicion, the definitive test confirmed the diagnosis. A sweat chloride was positive on 2 different occasions. Final confirmation came from whole exome sequencing identifying the CFTR gene mutation and diagnosing the baby as a case of cystic fibrosis. The differentials included non-resolving pneumonitis, pulmonary tuberculosis, primary ciliary dyskinesia, and severe combined immunodeficiency. Based on a positive sweat chloride test and whole exome sequencing, the final diagnosis was cystic fibrosis in this 3-month-old baby with recurrent cough and breathing difficulty. Coming to the treatment, the baby was first managed outside on day 15 of life with oxygen, IV fluids, IV antibiotics, nasal saline drops, and was kept nil per oral. As symptoms persisted, the baby was admitted at 3 months, requiring high-flow oxygen, IV antibiotics, and regular nebulization. With no improvement and worsening X-rays, antibiotics were escalated, and the baby was referred to a higher center, where oxygen and IV antibiotics were continued. A blood transfusion was given and cystic fibrosis was diagnosed. At 4 months, the baby was readmitted with worsening respiratory distress, started on high-flow oxygen, tube feeds, IV antibiotics and nebulization, but developed shock and respiratory failure, requiring inotropes and ventilator support. This is a chest X-ray post-intubation. The baby then suffered a cardiac arrest and despite resuscitation and escalation of care, could not be revived and was declared dead on 5th April of 2025. While this case shows how severe cystic fibrosis can be, advances in care have improved outcomes. Treatment now includes antibiotics, airway clearance, nutrition support, and CFTR modulators. Early diagnosis through newborn screening and genetic counseling also help in guiding care and family planning. Unfortunately, in this case, the baby could not access all the treatment needed. Therefore, through this case, I hope to raise awareness and make the treatment more accessible to everyone. Thank you.
Hello.
Since you this should be included in neonatal screening, what is the incidence of cystic fibrosis?
Ma'am, the incidence is around 30%. Like the last 2021 studies I have read, it was 30% in India.
30% is very high.
Sorry, then I must be confusing the stats.
Okay. What are the commonest presentation? Now, this particular patient presented with respiratory complications.
Yes.
What would be the other common presentation which will indicate you to do the further investigation like CT?
Sorry, ma'am. Since this is a thank you for your question, ma'am. Since this is a neonate that just like he's still an infant, there would be delayed passing of meconium as well, and the frothy stools is another very confirmatory test for this case. And recurrent respiratory infections, while it has a lot of differential diagnosis, it also points to cystic fibrosis, and the family history also narrows it down.
Having cystic.
Sir, the life expectancy in 2021 it was 33 years. Now it has definitely increased to 56 years actually. The latest studies they say that.
There is a defect in the gene. So which chromosome is affected? The mutation occur at which chromosome?
Chromosome 7, sir.
What is the ultimate treatment for this cystic fibrosis?
Ma'am, ultimate treatment would be the CFTR modulators. If that, like ivacaftor, lumacaftor, if that is not working, then at an end stage, lung transplantation is recommended.
Okay.
Thank you so much.
Thank you.
Thank you, participant 1. Before moving on to the next participant, I would like to clarify the rules again. There will be a warning buzzer at 6 minutes. After that, there will be a final buzzer at the 7 minutes. Next, we invite participant 2 to present their case.
Lymphoma in a young female. Beginning with the case history, my patient is a 25-year-old female residing in West Bengal, hailing from West Bengal itself. She's a college student. Date of admission was 11 Jan and I've examined her on 12 Jan 2026. The history is given by the patient and the informant. Informant is a mother and the history is reliable. Chief complaints are she had multiple swellings in both sides of the neck since 3 years, significant weight loss of approximately 20 kg over the last 6 months, multiple swellings in both axillae since 3 months. History of presenting illness. Patient was apparently all right 3 years ago when in August 2023 she developed a low grade fever that was continuous, which relieved on paracetamol, not associated with any rash but associated with episodes of night sweats, joint pain and fatigue. Around the same time, she noticed multiple swellings all over the right side of her neck, insidious in onset, initially the size of about 2 to 3 centimeter, not associated with pain, redness, or discharge. She visited a local practitioner where a diagnosis of tuberculosis was made without any microbiological evidence and AKT was initiated. Even after 3 months of treatment, right cervical swellings gradually increased in size to about 4 to 5 centimeter. New swelling appeared in the left middle part of the neck, insidious in onset, size of about 2 to 3 centimeter, not associated with pain, redness, or discharge. She then visited a tertiary care center A where biopsy of the neck swelling and further evaluation led to a diagnosis of Hodgkin's lymphoma. Anti-tubercular therapy was stopped and she was initiated on ABBD chemotherapy and she completed 6 cycles between February and July 2024. Swellings in the neck during this period reduced to pea size but did not completely disappear. Fever, night sweats, joint pain, and fatigue subsided. However, PET CT scan demonstrated persistent disease and she was advised further treatment. She was then given GCD chemotherapy, completing 3 cycles between October and December 2024. During this period, the neck swellings remained stable in size and she remained asymptomatic. However, repeat imaging again showed inadequate response to therapy. Disheartened by multiple therapeutic failures, she discontinued conventional therapy and opted for Ayurvedic treatment for approximately 6 months. During this period, she experienced significant weight loss of about 20 kg accompanied by joint pain and fatigue without having fever or night sweats. Thereafter, her weight remained stable. In October 2025, she noticed multiple small swellings in both axillae while bathing, insidious in onset, not associated with pain, redness, or discharge. Around the same time, she noticed that the swellings in her neck became more prominent and gradually increased in size over the subsequent months. In January, that is currently, the neck swellings, which were initially pea-sized, have now enlarged progressively over the last 3 months, and now her largest swelling measures approximately lemon size. She also notices increased prominence of the axillary swellings on both sides. In addition, she now has hoarseness of voice since 1 month, not associated with sore throat or fever. She has persistent fatigue and joint pain without fever or night sweats. Owing to progression of swelling, she then presented to another tertiary care center for further treatment. There is no history of cough, hemoptysis, TB contact, chest pain, upper limb swelling, facial puffiness or dysphagia. There is no history of blood transfusion, high-risk sexual behavior, IV drug abuse. There is no history of persistent headaches, seizures, altered sensorium, ataxia or tremors. Past history, she's a known case of bronchial asthma since 12 years. She's taken ABBD and GCD chemotherapy in 2024. There is no history of any other malignancy in the past. Personal history. She denies any addictions. There are normal bowel and bladder habit, and she takes mixed diet. Now coming to general examination, she was examined after taking informed consent and a well-lit condition in both sitting in supine position. She's average build but poorly nourished. There was clearly loss of subcutaneous fat, prominent clavicle and ribs were visible with her BMI as 15.4 kg per meter square. Coming to vitals, the pulse is 84 beats per minute with regular rhythm and normal characteristics with all other peripheral pulses present. The blood pressure is 110 by 70 mmHg, respiratory rate 15 breaths per minute and temperature is 98.6 degree Fahrenheit. SpO2 is 98%, moderate pallor is present. She has bilateral cervical and axillary lymphadenopathy, which makes her a case of generalized lymphadenopathy, which is further described under local examination. Other lymph nodes were not palpable and there is no evidence of icterus, cyanosis, clubbing or edema. Local examination of the cervical region. On inspection of the right side of the neck, 3 swellings are visible on level 2, 3, 4. It is ovoid in shape, varying between 2 to 6 centimeter, the largest being present in level 4. The swellings have well-defined margins, the surface looks smooth, skin over the swelling head, no scar, ulcer, discharge or pigmentation, and there are no dilated veins visible. On palpation, there is no local rise of temperature or no tenderness. 3 discrete nodes were felt in level 2, 3, 4. The largest swelling in level 4 measures 6 by 5 centimeter. They have well-defined regular margin with a smooth surface and rubbery consistency. The swellings become less prominent on contraction of the right sternocleidomastoid against resistance. They are not fixated to skin, muscle or bone. They are not reducible or compressible. On inspection and palpation on the left side of the neck, a bandage was present over the anterior mid-cervical region corresponding to the site of prior excisional biopsy, hence it was not palpated. Axillary region. On inspection, there is no visible swelling. The skin has no scar, ulcer, pigmentation, or discharge. On palpation in the right axilla, multiple discrete lymph nodes were palpable in the central and posterior axillary groups, the largest measuring approximately 4 by 2 centimeter in the central group. The nodes were non-tender with no local rise of temperature, ovoid shape, well-defined regular margin with a smooth surface, rubbery consistency, and no fixity to skin, muscle, or bone. The left axilla showed multiple discrete lymph nodes in the posterior axillary group. Examination of the drainage sites were done, and there were no inflammatory signs in scalp, nasal cavity, or paranasal sinuses. Oral cavity was examined for any lesions, swelling, or any kind of ulcers. Thyroid was not enlarged, and both breasts were symmetrical with no palpable lumps. In systemic examination, gastrointestinal system, the abdomen was soft, non-tender, there was no organomegaly present. Respiratory system, there was symmetrical chest wall movements, bilateral air entry was equal, and on sternal percussion, there was no dullness appreciated. Cardiovascular system, central nervous system, and skeletal system showed no abnormalities. On investigation, the first one is complete blood count, which showed microcytic hyperchromic anemia with leukocytosis, predominantly neutrophilia. The recent whole body PET scan done compared to the previous PET CT of February 2025 showed significant increase in size and metabolism of most of the previously seen lymph nodes, and there was new onset pulmonary involvement which is suggestive of disease progression. On cervical lymph node excisional biopsy, there were scattered Reed-Sternberg-like cells present. On immunohistochemistry, it was CD30, CD15 positive with PAX5 weak staining present. Differential diagnoses are refractory Hodgkin's lymphoma, tuberculous lymphadenitis, and infective lymphadenopathy. Final diagnosis was refractory Hodgkin's lymphoma, nodular sclerosis subtype, stage 4. For management, apart from the nutritional optimization, folic acid supplementation, and symptomatic management, she is now given salvage chemotherapy with ICE regimen in combination with nivolumab along with autologous stem cell transplantation. This is the summary of my case, and I'll conclude my case here.
When will you recommend doing a biopsy of the lymph node or against the FNAC if you see a case of generalized lymphadenopathy?
In a case of generalized lymphadenopathy, when FNAC shows no diagnostic, the FNAC is doubtful, or there is no lesion seen in FNAC, or there is no microbiological evidence of tuberculosis, then excision biopsy is preferred. And even in cases where clinical examination and other investigations are pointing towards a lymphoid malignancy or any other hematological malignancy, then excision biopsy is always preferred over FNAC.
In excision biopsy, the diagnostic part is the Reed-Sternberg cell. How it looks like?
Reed-Sternberg cells are large cells which are about 5 to 6 times more in size than regular lymphocytes. They have multi-lobe nucleus, classically mirror-shaped nuclei with a prominent eosinophilic nucleoli.
In your differential diagnosis, you have not mentioned non-Hodgkin's lymphoma, which is one of the Hodgkin's and What is the basic difference between these two?
The basic difference between non-Hodgkin's and Hodgkin's is that Hodgkin's follows a predictable lymphadenopathy of the contiguous lymph nodes. Like after cervical, it will proceed to axillary without skipping any lymph node in the middle, whereas non-Hodgkin's lymphoma presents with a widespread lymphadenopathy, and more commonly it has visceral disease, and here visceral disease was not present. And also the reason for not putting non-Hodgkin's lymphoma is that it is more common in elderly, and my patient is a 25-year-old young female with no risk factors for any kind of malignancy.
If the patient gets early treatment, what is the survival rate for the patient?
For Hodgkin's lymphoma and especially for nodular sclerosis subtype, the survival rate is about 85 to 90%.
What is the role of stem cell transplantation?
Because it is a very toxic chemotherapy which is now being given to her, there's high risk. Even we can say that definitely her bone marrow is going to be damaged. So because we are able to give these toxic doses of the current chemotherapy because of the stem cell transplantation which is going to be done.
In the history you had mentioned that this patient had bronchial asthma. since last 12 years. Is it significant for us?
Yes, ma'am, it is very significant because many of the chemotherapy drugs are toxic to the lung and we need to modify their doses. For example, she was given bleomycin, but the dosage for her was modified because of her condition, that is bronchial asthma, to prevent lung fibrosis causing a severe disease progression.
Okay, thank you.
Thank you, ma'am.
Thank you, participant 2. Moving ahead, we now call upon participant 3.
Your name is Shreyas.
Good morning, respected judges and organizers. I am Shreyas Ramakrishna, and today I'll be presenting a rare and a diagnostically challenging case, Sjogren's-Larsen syndrome with diplegic cerebral palsy and global developmental delay. Sjogren's-Larsen syndrome, or SLS, is a rare autosomal recessive neurocutaneous disorder caused by a deficiency of fatty aldehyde dehydrogenase leading to defective oxidation of fatty alcohols. Clinically, it presents as a classical triad of congenital ichthyosis, spastic diplegia, and intellectual impairment or developmental delay in 2 or more than 2 domains for children under 5 years of age. Now, each of these can be seen in isolation, but their coexistence in one child makes this case exceptionally rare and educationally important. Our patient is a 4-year, 7-month-old Hindu girl, firstborn child of a second-degree consanguineous marriage who was brought to the pediatric OPD with chief complaints of dry scaly skin since birth, inability to walk or stand without support, which progressively worsened, and a progressive increase in the stiffness of the lower limbs until the time of presentation. There was no history of seizures, regression, or infections, but the parents noticed motor and language delay. Although there wasn't any significant past history, the child showed altered bowel movements with an impaired bladder control. Social interactions and motor involvements were limited due to developmental delay. The family history, as we can see in the pedigree chart shown on screen right now, was significant for consanguinity, therefore suggesting a genetic etiology. Birth history revealed a low birth weight baby weighing 2.2 grams at the time of birth, delivered via lower segment cesarean section with ichthyosis noted at birth along with mild hypotonia. The patient was admitted to the NICU, which is the neonatal ICU, for 5 days for feeding difficulties and over the next few years developed progressive stiffness of the lower limbs. Mild oligohydramnios was noted as a congenital anomaly with an amniotic fluid index of 4 centimeters. The child was underweight with respect to the protocols of WHO, which is the ideal weight management at the time of presentation. These are the following treatment modalities and therapeutic modalities which were prescribed prior to their presentation, and these are the developmental delays which were noted in the child. Both the mother and the child were completely immunized till date, with further assessment revealing the patient belonging to a class 4 socioeconomic status according to the modified BG Prasad scale. The clinical examination was done in a well-lit room with prior informed consent taken from the mother of the patient, who is not only a consistent but also a reliable source of information. On examination, the child was conscious, cooperative, and well-oriented to time, place, and person. Although the vitals were completely normal, physical examination confirmed that the patient was malnourished and moderately pale. These can be correlated with the anthropometric markers which have been displayed on the screen. Neurologically, she had spasticity in both lower limbs with a power of 3/5, with brisk tendon reflexes, bilateral ankle clonus, and a scissoring posture that worsened on suspension. Upper limbs showed mild hypertonia and plantar responses were extensor bilaterally. The cranial nerves and sensory examination were normal. Dermatologically, there was a generalized ichthyosis with fine scaling, thickened hyperkeratotic plaques, and pruritus, which are the classic dermatological signs of SLS. Now, this profile pointed towards spastic diplegia cerebral palsy, but the concurrent ichthyosis and developmental delay, we suspected a metabolic leukodystrophy rather than an isolated cerebral palsy. These are the images of the child on presentation. The provisional diagnosis includes ichthyosis, diplegic cerebral palsy, and developmental delay. The investigations of MRI brain revealed mild hyperintensities with bilaterally symmetrical flare hyperintensities in the posterior parietal and peritrigonal white matter, consistent with leukodystrophy and periventricular myelin abnormalities. Basal ganglia, thalamus, and cerebellum were completely normal. The electroencephalogram showed encephalopathic changes correlating with neurodegeneration. When these findings were correlated clinically, ichthyosis, spasticity, and developmental delay, the diagnosis strongly favored Sjogren's-Larsen syndrome. These are the MRI findings, as we can appreciate on the screen. Hence, the final diagnosis is of Sjogren's-Larsen syndrome presenting with diplegic cerebral palsy and global developmental delay. While biochemical confirmation for the fatty aldehyde dehydrogenase deficiency can be done, the clinical and radiological correlation is extremely important in this case. The management was multidisciplinary, tailored to both symptomatic relief and developmental optimization. The neurological management included oral baclofen, botulinum toxin injections to reduce spasticity, and regular physiotherapy and gait training to prevent contractures, hydrotherapy and hippotherapy for balance and posture, speech and occupational therapy to support language and fine motor development. The dermatological management included urea and lactic acid-based emollients, salicylic acid ointments, and gentle bathing routines to control ichthyosis and maintain skin comfort. The developmental management included early cognitive stimulation, special education programs, and parental counseling, which was initiated. Nutritional optimization was done with a high-calorie, high-protein diet, along with vitamin D and calcium supplementation to address the malnutrition and immobility risks. Equally important were the psychological support for the parents and the genetic counseling to explain the inheritance pattern and the recurrence risk. A structured follow-up plan was planned involving a multi-specialist approach tailored to symptomatic relief. Though the condition is non-progressive, spasticity and intellectual delay can persist, hence the recognition and coordinated management makes the difference. To conclude, this case reminds us that not every cerebral palsy is hypoxic. The prevalence of Sjogren's-Larsen syndrome is very rare, usually amounting to a mere 1 in 250,000 mid-year population, and furthermore in a rural setup, wherein this case was reported, thus making it exceptionally rare and diagnostically challenging. In a rural setup with limited access to specialized care, early suspicion, multidisciplinary teamwork, and compassionate follow-up can transform the outcomes for such children. Here are the references that were used for the study. I would like to acknowledge every person and organization involved in the completion of this case. Thank you very much.
What is the prognosis in this case?
Ma'am, so this case has a slightly poor prognosis in Sjogren's-Larsen syndrome because the chances of it progressing to a much severe condition is very high. It can't be cured, therefore a symptomatic relief treatment is planned, wherein the dermatological, because it's a neurocutaneous disorder, a neurological and a dermatological pattern is followed for the management, wherein as mentioned, oral baclofen botulinum toxin can be given for controlling the neural degeneration, and ointments and topical and symptomatic relief can be provided for the patient to control the dermatological management of this case.
What are other neurocutaneous syndromes you know of?
Ma'am, other syndromes are basically types of ataxic cerebral palsy, diplegic cerebral palsy, Refsum syndrome. Then you have hemiplegia associated with cerebral palsy, etc. There is Weber syndrome. Many syndromes are there.
Is there any stages in this syndrome? Different stages?
Sir, so in Sjogren's-Larsen syndrome, initially the child will present with ichthyosis, which is the dermatological sign, but eventually it will progress into developmental delay, although it won't be a true regression. It will be a developmental delay compared to the normal. Therefore, we can notice at every single stage as this disease will progress. These are the main stages of the syndrome.
Which malignancy is closely associated with this syndrome? Any malignancies usually or many times you gets associated with this?
Sir, sometimes since there is an immunological deficiency, skin cancers and other similar dermatological malignancies can be associated with this particular syndrome.
Okay. Thank you.
Thank you very much.
Thank you, participant 3, for your valuable contribution. Next, we welcome participant 4.
Good morning, everyone. I'm Gauravi Lombar, and today I bring before you a case of double outlet right ventricle with a complete atrioventricular septal defect. A DORV is a heterogeneous congenital cardiovascular malformation characterized by both arterial trunks arising predominantly from the right ventricle. Meanwhile, a complete AVSD comprises an ostium primum type of ASD, a common AV valve, and an unrestricted VSD of inlet type. The precise prevalence figures for this cardiac anomaly are not known due to limited epidemiological data. Some syndromic associations include trisomy 13, trisomy 18, and trisomy 21. My patient is a 3-year-old male child, firstborn to a 21-year-old mother out of a non-consanguineous marriage. He was born at a rural PHC and had no perinatal complications or NICU admission. At just 15 days of age, he presented to a local doctor with complaints of poor feeding and excessive sweating during feeding and sleeping, where on evaluation, a peripheral cyanosis and a cardiac murmur was noted. A 2D echo at a higher center revealed a DORV with a large inlet non-routable VSD, an additional muscular VSD, a moderate ASD, and a common AV valve. Owing to the non-routable nature of the VSD and a common AV valve, a staged surgical approach for single ventricle physiology was opted for as a palliative management. My patient underwent pulmonary artery banding at 4 months of age, followed by a bidirectional Glenn shunt procedure at 1 year of age. He at present awaits Fontaine completion. Here we have a representational image of the staged surgical approach. The family history, antenatal history, and birth history were non-contributory. The family belongs to upper lower class according to modified Kupuswamy scale 2024. His developmental history indicated a global developmental delay with a severe delay across all 4 domains. Clinically, he was conscious, irritable, and not playful. His build appeared to be small for his age. Peripheral cyanosis and clubbing were seen in the nail beds, and SpO2 was less than 80% in all limbs. Anthropometry revealed that he was underweight, stunted, and moderately undernourished. On systemic examination, cardiovascular system revealed a soft S1, loud S2, and a grade 4 pansystolic murmur heard best at the lower left sternal border. Respiratory examination revealed lower chest retractions and a decreased chest wall expansion. On CNS examination, a reduced muscle bulk was seen and a reduced power of grade 3/5 was seen in all major muscle groups. Abdominal examination was unremarkable. On investigations, X-ray revealed cardiomegaly. ECG showed sinus tachycardia, right axis deviation, and a P pulmonale and P mitral was seen, suggestive of biatrial enlargement. 2D echo revealed a well-functioning Glenn shunt to the right pulmonary artery, and a moderate regurgitation was newly diagnosed in the common AV valve. The management for my patient can be classified under 4 main domains. General management includes parental counseling, screening for caregiver fatigue, advice on oral and dental hygiene, and enrollment under national and state health programs. Medical management includes nutritional rehabilitation, correction of anemia, and prophylaxis against infective endocarditis. We also formulated a diet plan tailored to the child's calorie and protein requirements based on recommendations given by Centino Malfaz et al. Surgically, as my patient does not meet the criteria of age and AV valve sufficiency, he is at present ineligible for Fontaine completion. Seng et al. Identified that an AV valve regurgitation was a significant risk factor to Fontaine failure, long-term mortality, and cardiac transplantation. Thus, an AV valve repair is indicated prior to it. As shown in the slide here, children with chronic illnesses have a higher prevalence of behavioral, social, and emotional difficulties. Demasso et al. Identified that a 65% lifetime prevalence of psychiatric illnesses in these children, which emphasizes for interventions such as play therapy, family therapy, cognitive behavioral therapy, and eventual pharmacotherapy. Following Fontan completion, long-term monitoring of the cardiovascular system and end organ system surveillance testing is essential to assess for Fontan failure. My patient has the non-modifiable risk factors of male sex, common AV valve, and AV regurgitation prior to Fontans, which are associated with the poor prognosis. Marshall et al. Identified that psychological factors were the strongest correlates of global and health-related quality of life among patients with Fontan physiology. To summarize, this case of a child with a DORV and a complete AVSD has its clinical course complicated by an AV valve regurgitation, chronic undernutrition, and recurrent infections. To him, surgery is just the beginning, with his long-term outcome dependent equally on nutrition, neurodevelopment, a structured transition into adult congenital heart disease care, and lifelong follow-up. When we take a step back from the specifics of this case, several key themes arise. Single ventricle palliation is a lifelong physiological compromise requiring repeated hospital contact and long-term care. It also brings into question caregiver fatigue, which not only influences the family environment but also the child's development. His overall outcomes being influenced by multiple interconnecting factors. When palliation fails, cardiac transplantation remains the only definitive treatment option. While there is Indian data on surgical management, data on nutrition, psychological interventions, and long-term follow-up of these patients remains limited. Further research could help solidify the cardinal goal of giving these children a fair chance to go from surviving to thriving. Thank you. Here are the list of my references and the WHO growth charts. Thank you.
What are the types of DRV?
The types of DORV are based on the anatomical position of the VSD. It can be a subpulmonary VSD and a non-committed VSD or remote VSD. And based on the presentation of clinical features, it is TOF-like presentation, VSD-like presentation, and TGA-like presentation.
Okay. So, what you think? How suppose such patient comes to you? How you will counsel them? Counsel the parents also.
So to counsel the parent, because this case has a reduced life expectancy as compared to other children, we could stick to the spikes protocol, and also firstly counsel the parents about the reduced life expectancy, but also that with timely interventions and with regular follow-up, he can live up to the expected life expectancy for these children.
Which is the better, whether this double DORV or a TOF? What is the basic difference, and who has got the better prognosis?
The basic difference is that tetralogy of Fallot is a group of disorders, and DORV is the aorta arises primarily from the right ventricle. The better prognosis is in tetralogy of Fallot, not only because of their earlier presentation, but also because definitive treatment outcomes are available for this condition. While DORV, there is biventricular repair available. For this patient specifically, univentricular had to be chosen. And
whose prognosis is better in these two cases?
Tetralogy of Fallot is a better prognosis.
Okay, thank you.
What was the name of this case you have put as Sisyphus? What does it indicate?
Ma'am, Sisyphus is actually a Greek character who was condemned to roll a boulder uphill for the entirety of his lifetime. So the main...
that was the punishment.
It depends on perception actually, because it can be a punishment or perseverance if we look at it. And this child has to live with his condition throughout his life, which will be an uphill struggle, but it will be a journey nevertheless.
Why have you included the psychological aspect so much? Because what is the age of this patient?
3 years, ma'am.
3 years old. So how do you assess him psychologically at this condition, or do you want to talk about the parent psychology more?
Actually both, but primarily for the child. Several foreign studies have shown that these children, when intervened on the psychological basis earlier in life, they have a better prognosis than the kids that did not have any psychological interventions like play therapy or just stimulation in early childhood development. So if we intervene on the psychological aspects earlier, we can expect a better quality of life for this patient.
Now, this particular patient was delivered in a PHC, a rural setup. Suppose if you would have delivered it in an urban setup, do you think there would have been difference in the management?
The management would have been different if he would have been delivered in an urban setup, but primarily related to the presentation and the basic checkups that we do for neonates in an urban setup. So it would have been different in an urban.
What about the prevention, like early diagnosis, and maybe if you diagnose early, then maybe abortion could have been the better option for this particular parents? You not mentioned about that.
Thank you, ma'am.
Thank you, participant 4, for that insightful presentation. Next, we invite participant 5 to present their case.
Good morning, respected professors and my dear colleagues. I am Avnish Prajapati, a third-year MBBS student. Today I will be presenting a case on neuromyelitis optica, spectrum disorder, and rare autoimmune demyelinating disease that primarily affects the optic nerves and the spinal cord. A 50-year-old male resident of Ramtek, Nagpur, shopkeeper by occupation, came to IOPD with complaints of gradual progressive diminution of vision in the right eye since 5 weeks. History of presenting illness. Patient was apparently all right 35 days back. When he noticed blurring of vision in the right eye, the vision progressively deteriorated over the 5 days. Now he cannot perceive light in that eye. It was associated with dull aching pain, for which he came to the hospital and was admitted for further evaluation. Then he was given IV steroids and was put on 5 cycles of plasmapheresis. Negative history. No history of fever, no history of watering of eye, no history of photophobia, no history of trauma, no history of redness of eye, no history of gritty sensation, no history of frontal headache, no recent infection and vaccination. Past history, history of left-sided hemiparesis last year in February 2024. When he came last year in Feb 2024, he came to the hospital with chief complaints of hematemesis and was diagnosed with Mallory West tear. Personal history, no history of altered bowel and bladder habit, no history of any addictions, no history of sleep alterations, appetite is normal. Family history, there is no family history of similar neurological illness or autoimmune disorder. General examination, the patient is conscious, cooperative and oriented of time, place and person. Temperature is afebrile, pulse is 80 beats per minute, which is regular in rhythm, normal in volume and character, equal on both sides with no radiofemolar delay. Respiratory rate is 17 per minute. Blood pressure is 130/180 mm of mercury. No pallor, icterus, cyanosis, clubbing and lymphadenopathy. On CNS examination, we find normal tone, normal reflexes, sensation is normal, power is 5/5 in all muscle groups, sensation is normal, cranial nerves. Cranial nerve 1 is normal, cranial nerve 3 to 12 are normal, cranial nerve 2 on examination was found abnormal. Visual assessment, visual acuity of the right eye, no perception of light. Pupillary reaction, grade 3, relative afferent pupillary defect. Light reflex, absent. Pain on movement, absent. Let's come to the differential diagnosis. In terms of differential diagnosis, we have neuromyelitis optica, myelin oligodendrocyte glycoprotein antibody mediated disorder, multiple sclerosis and sarcoidosis. In order to eliminate the other diseases, we'll have to do serological testing. Serum aquaprotein 4 antibody IgG test is done. Cell-based assay is done and it is highly specific for neuromyelitis optica. myelin oligodendrocyte glycoprotein antibody is also tested. This is negative in neuromyelitis optica, and that is a high specific test in order for us to conclude the diagnosis. On CSF analysis, we find oligoclonal bands which are less than 30% in neuromyelitis optica. Radiological evidence, MRI brain and spine with contrast, we will find longitudinal extensive transverse myelitis involving more than 3 vertebral segments. Relapsing neuromyelitis optica spectrum disorder is the final diagnosis, and the 2 pillars that we have in concluding is the aquaporin 4 IgG serology and the history of hemiparesis, which is related to longitudinally extensive transverse myelitis. One another thing that also can be related with the Mallory-West syndrome. Treatment strategy: in the acute phase of treatment, we'll give him prednisolone 1 gram per day for 5 days, and the other alternative is plasma exchange, which removes the circulating antibodies. In the long-term treatment, we'll give him inbilizumab, and the alternative drugs would be sartalizumab, eculizumab. The patient will be advised for strength training, mobility exercises, compliance, and we'll monitor his glucose, BP, bone health, and weight. So here's an overview of the disease. In terms of epidemiology, it is 1 upon 10 per lakh globally. It is more common in Asians and Africans. In terms of prognosis, we have 50% blindness if untreated and 10% blindness in the next 5 years if treated. Here are my acknowledgements. I extend my gratitude towards my teachers, seniors, peers for the invaluable guidance, support throughout this case presentation. Special thanks to my patient and his family for cooperating during the clinical evaluation process. Thank you.
What are the other causes of sudden blindness?
Ma'am, the causes of sudden blindness can be a trauma, or it can be an infection of some kind. Viral infections are majorly the triggers of blindness that I have observed, and inflammatory disorders such as neuromyelitis optica, multiple sclerosis can also be associated with blindness.
This patient presented with visual problems first or hemiparesis first?
Ma'am, the patient usually presented with hemiparesis in the February 2024, and later it was not well diagnosed, and when he came back on losing his vision of right eye, at that time he was diagnosed with neuromyelitis optica.
So was he given plasmapheresis and methylprednisolone before his visual findings, or it was after the findings?
Ma'am, steroid therapy was started voluntarily, but then it was stopped, and it was initially continued after he was diagnosed finally with neuromyelitis optica.
Who started this voluntarily?
Primary healthcare center.
And plasmapheresis was done at what stage?
It was done after neuromyelitis optica was diagnosed.
Okay.
What is the triad of relapse in case of neuromyelitis optica? What is the triad for the diagnosis?
Sir, bilateral neuritis, aquaporin 4 IgG and
Bilateral neuritis of what?
sorry,
Bilateral neuritis? Which nerve?
optic nerve.
Okay, then?
And transverse myelitis and brainstem syndrome.
No. What is the gold standard investigation for this disease?
The cell-based assay based on aquaporin 4 protein antibody IgG.
Okay, thank you.
Is it reversible or it is?
It is irreversible, ma'am.
Okay.
Thank you, participant 5. Moving ahead, we now call upon participant 6.
Good morning, judges. So, today I'll be presenting a rare case of Miridji syndrome with complete impaction with giant CBD and CHG stones. So, starting with patient demographics, our patient Mrs. XYZ, a 70-year-old female, resident of Govandi, unemployed by occupation, came with the chief complaints of fever with chills since 4 days and pain in abdomen since 4 days. So in the history of presenting illness, the patient was apparently all right 4 days ago when she presented with the above following symptoms. Onset of fever was sudden in onset and gradually progressive, not relieved by medication. Fever episodes were low grade, present throughout the day, associated with chills and rigors. The fever episodes were not associated with any evening rise in temperature, myalgia, retroorbital pain, arthralgia, burning micturition, or night sweats. The abdominal pain was sudden in onset, gradually progressive, and localized in the right hypochondrium, throbbing in nature and non-radiating, and again not relieved by any medication. The abdominal pain was accompanied by vomiting episodes. These vomiting episodes were non-blood-stained, non-bilious, and had undigested food particles in it. So the patient had no past history of any trauma, no past history of any abdominal TB or pelvic inflammatory disease, no history of any outside food consumption. The past medical history showed the patient is a known hypertensive since 20 years on tablet amlodipine, no past history of diabetes, hypothyroidism, TB, or asthma. So the past surgical history showed a total abdominal hysterectomy 15 years back and history of cataract surgery 10 years back. Family history was not significant. So in general examination, patient was examined with due consent in a well-lit room. Patient was conscious and well-oriented in time, place, and person. The pulse was 80 beats per minute, blood pressure being 118 by 60 millimeters of mercury. Respiratory rate was 14 breaths per minute. No pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. The systemic examination, the abdominal examination showed inspection, normal shape of abdomen was noted, umbilicus being central and inverted, past scar of hysterectomy was seen, no ascites, distension, organomegaly, palpation showed no positive palpatory findings, as I said, and no organomegaly in palpation. The percussion showed tympanic node over the stomach, dull node present at the liver, and no other positive findings were seen, and in auscultation we could hear the bowel sounds. Respiratory rate, air entry was bilateral equal, both heart sounds were heard. Patient was conscious and oriented in central nervous examination. So, provisional diagnosis would include acute cholecystitis, cholangitis, acute pancreatitis, or choledocholithiasis. These were the blood investigations with the total bilirubin being 0.3 mg per dl, indirect bilirubin being 0.2 mg per dl, direct being 0.1 mg per dl, AST being 22, ALT 13, alkaline phosphatase 257. CBC was also relatively normal, except you could see that serum amylase and lipase also within their normal limits. Triple H was also non-reactive. So further radiological investigations was planned, which included the following order as they were performed: the ultrasound abdomen plus pelvis, followed by CT, which was plain CT abdomen plus pelvis, followed by MRCP. So the dilated common bile duct was seen with the underlying query for gallstone on the ultrasound. The CT findings showed a dilated common bile duct with a large non-calcified stone measuring 4 into 1.9 into 1.8 centimeters. The MRCP showed a contracted gallbladder with a calculus of 6 to 7 millimeters with a large lobulated column of T1, T2 hypotenuse area seen occupying the entire CHD and CBD, which as relates to my topic of large impaction stones. So there was a moderate to significant intrahepatic biliary dilation, and the patient was counseled regarding the following findings, and a diagnosis of cholecystitis was made. Patient was counseled regarding an open CBD exploration because of the large impacted CBD and CHG stones. So the intraoperative findings when the patient an open laparotomy was performed, and a cholecystoenteric fistula between the gallbladder and first part of duodenum was seen, which shows the rare anomaly of Miridji syndrome type 5. A large choledocolith was extending into the common hepatic duct. So basically the fistula was identified, it was excised and cut, and basically the entire CHD and CBD was washed out with about 100 saline washes, which I'll show in the next image, and the entire intrahepatic biliary tree was cleared out. A choledochoduodenostomie was done, and post-operatively patient was vitally stable. So these are the images, intraoperative image. If you see where the artery has been kept is where the fistula was found. There you see in the second and third images the retracted gallbladders. The gallbladder was retracted, and in the third image also included with the fistula and the gallbladder in its presence. So if you can see, there is a measurement of how dilated the intrahepatic biliary tree was in the second image. The first image is again showing the fistula being excised, and this is the complete picture of the proper fistula with the first part of duodenum and the gallbladder. If you can see, there is a final anastomosis, and there you can see about the number of gallstones that were removed. About 60 gallstones, tiny gallstones are removed, and 100
saline washes were given to clear out the entire intrahepatic biliary tree. So in summary, I would like to say such cases of Mersey syndrome are seen in less than 1% of the cases, and these peculiar findings of the case was that you would always see obstructive jaundice in a patient with such large CHG, CBD stones impacting, with the patient coming with severe pruritus. But here the patient did not present with any symptoms of obstructive jaundice, mainly being because there was a fistula draining the bile constantly, so there was no obstruction that was seen. And this gave us a causative finding to diagnose also the type 5 fistula that we saw. So I would just like to say that such cases should be reported for its severity and a management protocol should be made. Thank you. These are my references.
What are the types of Mersey syndrome?
So there are 5 types of Mersey syndrome. So type 1, 2, 3.
Your case falls in which type?
So type 5A, because it was Mersey syndrome without the gallstone ileus present.
Okay, what are the different types?
So the first type being the inflammation adhesion that you see because a large gallbladder stone impacting on the common bile duct. Type 2, 3 and 4 involves the cholecystobiliary fistulas involving less than 1/3 of the diameter of the CBD, between 1/3 and 2/3 of the diameter of the CBD and more than 2/3 of the diameter of CBD, involving complete destruction of the common bile duct. Type 5, as I said, being Mersey syndrome with the cholecystoenteric fistula, either with a gallstone ileus, type 5A, which is mine, or with presence of a gallstone ileus, type 5B.
So what is the difference between a Bovett syndrome with the Mersey syndrome?
Sorry, sir?
Bovett syndrome. Similar type.
Sorry, sir, I'm not.
Okay. What is the Courvoisier law?
So that law states that seldom palpable is a gallbladder in cases of obstructive jaundice. It is not due to underlying cholecystitis, but more of a malignant transformation that you see either in CA gallbladder or a periampullary carcinoma. Most people assume that you would find a palpable gallbladder in case of acute cholecystitis, but that's against the fact because you have a fibrosed and shriveled gallbladder in acute cholecystitis, and the law more for palpable gallbladder more go towards a malignant transformation of the gallbladder carcinomas.
Actually, the Bovett's law is a big stone in the duodenum, which presses the outlet of the stomach.
Noted, sir.
That is Bovett syndrome.
Yes.
So what is the diagnostic test for this Mersey syndrome?
So key diagnostic would be an magnetic resonance cholangiopancreatography. I said MRCP. Further ahead, would you like to do the ERCP also to visualize the...
allowed for some minimal interventional investigation, which is the diagnostic?
So CT abdomen plus pelvis.
ERCP.
Yes, I said after MRCP was ERCP, as I said, but today the final ERCP would be, because you can visualize the entire tree with the dye and the endoscope that is there, but if it's non-invasive, MRCP, if you go for invasive, then ERCP.
But only thing in your case, the typical classical case of Mersey syndrome, there is a single stone impacted.
Yes, sir.
But here there is a
multiple stones, and so the fact that she did not present with obstructive jaundice at all, she came completely the pruritus, and you could see the labs were absolutely normal, the ALP, the AST, they were all in the normal limits because the bile was being drained by the fistula
because
constantly.
multiple, there is no obstruction, and that's why this all parameter, liver parameter.
Very much, sir, exactly.
Limit.
Yes, sir.
Okay, thank you.
What was the cause of these multiple gallstones?
Ma'am, the cause of the multiple gallstones would be more towards the patient's diet when she was asked, I would say, because the lithogenic bile and stasis that was there. And not just this, she had past recurrent episodes of such pain in abdomen where the bile was possibly collecting and getting impacted in the intrahepatic biliary tree. So probably more towards pointing of a diet, of a high fatty diet, because lithogenic bile, there was stasis happening constantly. And because of constant inflammation which led to the formation of the fistula, because of the recurrent attacks that she kept having.
So at what stage, if the patient is coming with pain in abdomen, you will recommend doing all these investigations?
Ma'am, as soon as she comes, she came in a stage which was slightly delayed because she was staying in the village. But you would recommend the moment a patient presents with pain in abdomen and such symptoms, fever as such, they should get themselves investigated immediately. You can't plan them for open laparoscopic cholecystectomy if possible.
Okay.
Thank you.
Thank you, sir.
Thank you, participant 6, for your valuable contribution. Next, we welcome participant 7.
Good morning, everyone. we often encounter pediatric patients with vague complaints like fatigue, chronic pain, and poor growth. Most of the time, we attribute this to nutritional deficiencies or lifestyle factors. But how often do we think of any rare renal disease? Today, I present to you a case with similar complaints. Unveiling a renal enigma, a rare case of pediatric elixir imbalance. My patient is a 15-year-old male residing in Dharashiv, born out of a consanguineous marriage and brought to the OPD by his mother with chief complaints of generalized weakness and fatigue for 2 years, chronic back pains which worsened recently, and pain in both the limbs since past 15 days. On detailed history taking, the pain and fatigue was gradual in onset, progressive in nature, and temporarily relieved on medication. The mother also reported that for the past 10 days he had difficulty in walking and appeared short as compared to other children of his age at his school. Additionally, he had increased urinary frequency. There was no history of vomiting or diarrhea, chronic cough, recurrent respiratory infections, no history of trauma or blood transfusion. Past history revealed an episode of seizure at 1.5 years of age. He had inadequate mixed diet, disturbed sleep, and increased urinary frequency. Family history was not significant. Birth history, it was a term vaginal delivery with no NICU admission. Immunizations were up to date and all developmental milestones were achieved at appropriate age. On general examination, he appeared undernourished and short for his age. Vitals were stable. On anthropometry, it revealed height of just 125 cm and weight of 19.5 kg, both parameters corresponding to -3 standard deviation for his age and sex. On systemic examination, it showed visible muscle wasting and power was 3/5 across all the limbs. The systemic examination of CNS, abdomen, CVS, and respiratory system were normal. Given the chronicity of the disease, we proceeded with a detailed examination. CBC count was normal. Serological findings revealed hypokalemia, hypochloremia, hypomagnesemia, and hypophosphatemia. Urinary analysis showed increased level of urinary calcium and chloride excretion. ABG analysis showed metabolic alkalosis, and ECG revealed prolonged PR interval with sinus arrhythmia. The X-ray of spine and pelvis were normal, while the USG abdomen showed bilaterally bulky kidney with increased cortical echogenicity. We assessed the patient based on 3 key parameters. First, hypokalemia, then blood pressure, and increased cortical echogenicity and metabolic alkalosis. First, we ruled out the non-renal causes of hypokalemia. It included low intake, hypothyroidism, and insulin excess. All of these were excluded. With the normal BP, we proceeded for acid-base status. The ABG analysis report showed metabolic alkalosis. Further investigations were urine chloride levels. It showed an increase. This narrowed our investigations to Bartter syndrome or Clittelman syndrome. To differentiate further, we assessed the electrolyte levels, blood pressure, and aldosterone status. Bartter presents with hypokalemia, hypochloremia, increased urinary calcium, increased urinary chlorine, high aldosterone, and normal BP. While Clittelman syndrome has low urinary calcium. We also ruled out Liddle syndrome, which presents with hypertension and low aldosterone levels. Now, vomiting and cystic fibrosis can mimic Bartter, but are ruled out by history, low urine chloride, and chloride sweat test. All these diagnoses pointed towards a diagnosis of Bartter syndrome, a rare renal autosomal recessive disorder affecting the thick ascending limb of the loop of Henle, causing defect in sodium, potassium, and chloride reabsorption. This leads to salt wasting, volume depletion, and hypokalemic metabolic alkalosis. The parents of the patients were informed about the condition and reassured that even though it's a chronic condition, it's manageable. The patient was started with tablet cholecalciferol, syrup KCl, tablet indomethacin, tablet calcium, and tablet spironolactone. Now, you must be thinking, what is the patient's condition right now, as this disease requires long-term treatment? After a 2-month follow-up, the condition of the child showed better improvement. He had increased appetite, less limb pain, and showed interest in activities at school. His mother also reported that he had started his daily activities. So, to conclude, this case reminds us of the importance of a high index of suspicion in pediatric patients with chronic fatigue and poor growth. With the prevalence of just 1 in 1 million, Bartter syndrome can be easily missed. This case is a powerful reminder that even common symptoms can have rare causes. But with timely and systemic diagnosis, the prognosis is favorable, and appropriate interventions can prevent long-term complications, allowing these children to live healthier lives. Thank you.
How early the Bartter syndrome is presented?
Thank you for the question, ma'am. The Bartter syndrome has 5 types. So, as early as it can be seen after the birth, that is type 1, which presents as failure to thrive.
Any other manifestations you will suspect that the patient could be suffering from Bartter syndrome?
Thank you for the question, ma'am. Sensorineural deafness is one of the symptoms which can be seen in the patient to diagnose Bartter syndrome. And polyhydramnios, if the history of the mother had polyhydramnios, it can be also suggestive of Bartter syndrome.
Okay.
What is the triad of Bartter syndrome?
Thank you for the question, sir. It is metabolic alkalosis, hypokalemia, and increased urinary calcium levels.
Hypochloremia is not a part of triad?
Yes, it is. I said hypokalemia, metabolic alkalosis.
Chloremia, not kalemia. Chlorides.
Yes.
Of chlorides.
Yes. Hypochloremia.
What is the other name of this Bartter syndrome?
Sorry, sir.
Salt wasting nephropathy. That salt wasting nephropathy.
Salt wasting nephropathy.
Okay. What is the difference between your Bartter syndrome and you have compared in the differential diagnosis? Gitelman's syndrome.
Yes.
Where exactly the problem occurs?
Okay. Thank you for the question, sir. In Gitelman syndrome, there is low urinary calcium levels, while in our Bartter syndrome, there is high urinary calcium secretion in the urine.
But in Bartter syndrome, a loop of Henle gets.
Yes, yes.
Where this Gitelman-Nauchi effect?
Thiazide.
Which part of the tables?
Which?
Part of the tables. Nephrons.
No, sir.
No?
No.
Okay. Since it's in the distal table.
Stenting. Okay.
Since one of the closest differential is use of diuretics, so how would you clinically or examination-wise differentiate between whether it's a diuretic overusage or it is a Bartter syndrome?
Okay, thank you for the question, ma'am. Firstly, we will take in the history if the patient is on diuretic abuse or not. If not, then it is eliminated that diuretic abuse is not there. So in our patient, we asked for the detailed history taking. So there was no abuse of diuretic. So we excluded that.
What is the prognosis?
Prognosis is good if the patient is compliant to medications. But if the patient is non-compliant, then the prognosis can not be that better. It can be worsened. Like the pain will be worsened, and there will be severe muscle wasting, and walking, like daily activities, will be hampered.
What is the inheritance in this?
It is autosomal recessive inheritance.
So can you prevent the disease?
Yes, by genetic testing it can be prevented, or at least we will know it beforehand.
Thank you.
Thank you.
Thank you, participant 7, for that insightful presentation. Next, we invite participant 8 to present their case.
Good morning, judges and everyone. I am Neha Savla, a third year medical student. So today I'll present a case which is a common disease, but it has an uncommon course. Thus, is it a diagnostic pitfall? So here's the case. A 60-year-old male patient, resident of Nala Sopara, working in a flour mill for 40 years, came with chief complaints of breathlessness since 2 months, chest pain since 4 days. Patient was apparently all right when he developed breathlessness on heavy exercise 2 months ago. It was insidious in onset, gradually increasing, aggravated while lying down, thus orthopnea was present. Patient also experienced chest pain 4 days ago. It was also insidious in onset, gradually increasing, associated with palpitation. It was central and substernal in location. It was not radiating Upon asking the patient also complains of low-grade fever since 2 to 3 months associated with chills, evening rise of temperature. Patient managed that with some medication. Along with that, patient also developed cough with expectoration. Since 1 month, it was purulent sputum. Patient mentions a 5 to 6 kg weight loss. There was no history of chronic cough, wheezing, or hemoptysis. There was no history of past TB infection or TB contact. No history of bilateral pedal edema or facial puffiness, hematuria. No history of reduced urine output or urine urgency, which rules out the kidney disorders. There was no history of paroxysmal nocturnal dyspnea. There was no history of dysphagia and dysarthria as well. No history of any seizures or any focal neurological defects. No history of headache, blurring of vision, and no history of nausea, diarrhea, abdominal pain, or jaundice. Patient denies of any previous hospitalization and denies of any blood transfusion. There were no comorbidities present, and family history was insignificant. Patient had normal appetite but disturbed sleep due to orthopnea. Patient consumed tobacco since 40 years, average 10 grams per day. Patient was moderately nourished, well built, oriented to time, place, and person, and afebrile. The weight was 60 kg, height was 155 centimeter, and BMI came out to be 25 kg per meter square, which is a normal limit. There was pallor noted, but there was no cyanosis, no icterus, no clubbing, no pedal edema or lymphadenopathy. The pulse rate was 76 beats per minute. It was regular but high in volume. There was no radial or radiofemoral delay. All peripheral pulses were equal. The BP was 128 by 74 mmHg, measured in sitting position. It has a wide pulse pressure. The SpO2 was 94%. The respiratory rate is 22 per minute. On inspection, there was bilateral symmetrical chest with normal precordium, apical beat in left fourth intercostal space, 1 centimeter lateral to the mid-clavicular line. There were no visible pulsation or thrills, no dilated veins over the chest, but a parasternal heave was present. On palpation, the patient has colon peripheral skin. On auscultation, there were bilateral cracks present in the base of the lung. Wheezing sounds were present on both sides. Unfortunately, the murmurs were missed. Thus, immediate ECG X-ray was advised. Cardiac markers test was also advised, and CBC was advised. The ECG report showed ST segment depression in V5 and V6. The troponin levels were raised, and the CRP was also raised. Thus, the patient was diagnosed as N-STEMI, and that treatment was started. In X-ray, there was diffuse pulmonary edema. All other reports were in normal range. There was suspicion of N-STEMI, and thus that medication was started plus nebulization was started. This is the ECG report of that patient, and these are the other reports showing the troponin raised and CRP raised, and there was significant anemia, thrombocytopenia, and leukocytosis also reported. Upon further proper history taking, patient also mentioned 2-3 episodes of syncope in the past 2 months. Thus, again, auscultation was done, and a pansystolic murmur in the tricuspid area was noted, and and ejection systolic murmur in the aortic area was noted. Also, there was jugular vein dilatation. Thus, a 2D echo and HRCT and a fever profile was advised. There was no presence of any Janeway lesion or ossular nodes. In the HRCT of thorax, again the pulmonary edema was seen, and in this sputum examination test for TB, the sputum test came out to be negative. 2D echo was advised to find out any valvular heart disease. Till then, the NSTEMI treatment was continued. In the investigation part, in the 2D echo, and severe AR and moderate AS was noted. In the HRCTC of thorax, centrilobular nodules were noted. Fever profile came negative. In fundoscopy, no root spots were found. Thus, the differential diagnosis here can be aortic regurgitation and AS, which can be a past lesion. Due to unavailability of urgent blood culture at a government hospital setup, the patient was started on empirical antibiotic treatment. The empirical treatment was vancomycin, rifampicin, and gentamicin. So the differential diagnosis can be, it's a fever of unknown origin, which has cardiac pathology. It can be occupational lung disorder, as the patient worked in a flour mill for 40 years. It can be non-bacterial thrombotic endocarditis, and there can be some structure valvular nodules, but the final diagnosis came as infective endocarditis, yet the culture report were negative due to no culture in the government setup. Since there is a delay, so there, the culture report came negative and the antibiotic was started prior to that. The management is that the patient is given gentamicin, rifampicin, and vancomycin. There is a 6-week plan for this treatment, and after that, valve replacement is started. So here, this case highlights that there is a complex presentation in this case, and since the patient had a flour mill occupation, occupational disorder were given importance, and simple murmur auscultation was missed out. Thank you.
Was there any history of any previous heart disease in this patient? Why it was not suspected?
No, ma'am. The patient denies for any past history of a cardiac condition.
So how do you think, why? What was the cardiac lesion? What was the reason of that cardiac lesion?
Ma'am, in the echo 2D and AS was noted. So as the patient is 60 years old, so it can be due to atherosclerosis due to aging.
So he can have aortic stenosis also and aortic regurgitation also,
yes,
with aging, both things together?
Yes, ma'am, that can be true, but we suspect that he had AS first, and because of that lesion, endocarditis was developed on AS, and thus AR was also developed because of endocarditis.
Surprisingly, this patient's heart rate was also normal, the respiratory rate was also normal.
The counts of
ma'am, the heart rate was a bit raised. It was
76 per minute, and the respiratory rate was 20 per minute.
Yes, ma'am. But ma'am, the heart rate has very high volume, which is a classical sign of AR called the water hammer sign, in which the volume is very high and it is a collapsing heart rate.
How long was the fever was there?
Ma'am, patient told that the fever was for 2-3 months, but it was an evening rise fever, and he did not have any chief complaint with that fever.
So how you will end up of diagnosis that it is a bacterial endocarditis? What are the positive findings and positive investigation that tells that it can be a endocarditis, bacterial endocarditis?
Yes, sir. Sir, the 2D echo shows that it is AS and AR has AR is most commonly due to infective endocarditis. The fever can be due to TB or any other infection, but the TB reports of the sputum came negative, so we suspect that it is due for AI only, for infective endocarditis.
What is Duke's classification for endocarditis?
Yes, sir. It says that there should be two major criterias or one major.
Two major criteria.
So that the culture report should be positive and the 2D echo should show vegetations on the cardiac valve.
So
Sir, yes, ma'am.
in your case, there was no clinical history which suggested cardiac problem. You had no fever in this patient, nor your one of the criteria which was there, which was positive. So I think it was very, and clinically, I do not understand how it was missed, the findings on clinical examination.
Yes, ma'am. Ma'am, here the culture report could have come positive, but since the antibiotic was started earlier because the condition was very hampered and any complication could have been developed. So ethically, the antibiotics were started and then the culture
Ideally, you can
given.
collect a blood culture before starting your first dose of antibiotic. If you want to really diagnose infective endocarditis, that is the first criteria.
Yes, ma'am, that's correct. But since the patient can go in complications, so ethically we started the antibiotics first instead of waiting for the culture report.
For PUO, other things you are supposed to rule out. You have not ruled out about other types of fever profile. Whatever the fever profile, you have not mentioned anywhere. Because the main complaint was fever, na?
No, sir, the main complaint was chest pain, and upon asking, he said that the patient had fever.
But you told evening rise of fever since 1 month.
2 to 3 months.
2 to 3 months.
Yes, sir.
So, that is the main thing that you are supposed to rule out other causes of fever, na?
Yes, sir. So the fever profile was done and there was no other indication present. And since the 2D echo showed a prominent vegetation, so this was the best provisional diagnosis made. And the patient is showing improvement.
But vegetation in your echo where you have told there is vegetation. No. So your echo report, there is no vegetation in the valve.
No, sir, the vegetations were present. I have not added the report here, but the vegetations were present.
You do not have a blood culture report, you do not have a 2D echo report. So we want to diagnose this case as an infective endocarditis because the management is going to go on for at least 6 weeks of IV antibiotics. So you will have to convince the patient.
And CRP is also within normal limit, I think.
No, sir, CRP was
How
raised.
much it is raised?
Sir, the CRP was about 3 times raised.
How will you counsel this patient for valve replacement?
Ma'am, we can explain them the complications and I think just by telling them the complications, we can.
There is aortic stenosis, na? So what surgery you need to advise them?
So for aortic stenosis, valve replacement should be. Thank you, sir. Thank you, ma'am.
Thank you, participant 8. Moving ahead, we now call upon participant 9.
Good afternoon, everyone. I'll present my case. It's titled Descending Against the Norm, the Aman Twist in GBS. A 34-year-old married female, resident of Kalyan, homemaker by occupation, came to the hospital emergency with chief complaints of difficulty in neck holding and difficulty in swallowing since 1 day, bilateral lower limb weakness since 3 days, bilateral upper limb weakness since 5 days. Patient was apparently alright 5 days back when she noticed inability to raise left hand above the shoulder level, which she noticed while doing some household chores. She had weakness of left upper limb, which then progressed involving the right limb within 2 to 3 hours, for which she took some medications from a general practitioner, but she is not aware of those medications. The weakness progressed involving her lower limbs, initially needing assistance in standing and support while walking, but then after 2 days, she was unable to stand even on support. Thereafter, on 5th day, she had difficulties to hold neck and was unable to swallow solids or liquids. There is history of inability to speak. There is history of drooling of saliva. There is no history of sensory loss, seizures, imbalance, anosmia, vision changes or diplopia, no history of nystagmus, facial weakness or deviation, no history of diminished hearing or dizziness, no history of bladder bowel changes, no history of shock-like sensations. There is no history of diarrhea, vomiting or abdominal pain. There is no history of photosensitivity or rashes. There is no history of recent sore throat, no history of difficulty in breathing. There is no history of fluctuating or diurnal variation of weakness. There is no history of recent trauma, recent travel, or no history of prior such episodes. The past, family, drug history is insignificant. Personal history. Mixed diet with normal appetite, normal bowel bladder habits, normal sleep, and denies addictions. Obstetric history. Para 1 living 1, 5-year-old daughter delivered through vaginal delivery, no complications during antenatal, intranatal, and postnatal period. Summary. So a patient presented with acute quadriparesis with difficulty to speak and difficulty in swallowing. General examination, patient is conscious, cooperative, and well-oriented to time, place, and person. All her vitals were stable except for her SpO2, which was 98% on ventilator. There is no evidence of pallor, icterus, cyanosis, clubbing, or edema. Nervous system examination, higher function. Patient is alert, conscious, cooperative, well-oriented, time, place, and person, intact memory but unable to speak. There is bilateral loss of cranial nerve 9, 10, 11, and 12. On motor examination, there was no apparent wasting. Tone was decreased in all 4 limbs. Power at shoulder and hip joint was 1/5, whereas at elbow, wrist, knee and ankle, it was 2/5. Conjunctival and corneal reflexes were present, however, abdominal and plantar reflexes were absent. Deep tendon reflexes. Bicep jerk and ankle jerk was present, however, tricep, supinator, and knee jerk was absent. Coordination could not be assessed. There were no involuntary movements. Sensory system could not be assessed. There were no signs of meningeal irritation. Gait could not be assessed. Other systems, RS, chest movements bilaterally equal, vestibular sounds heard, and no additional heart sounds. CVS, S1, S2 normal, no murmurs. Abdomen, soft non-tender abdomen, no palpable organs. So at this point, we arrived at the following differentials. Stroke, mass at foramen magnum, Guillain-Barré syndrome, porphyria, transverse myelitis, multiple sclerosis. Investigations revealed leukocytosis, ABG revealed respiratory acidosis, CSF examination was non-remarkable, neuroimaging was unremarkable, electrophysiological studies revealed motor axonal polyradicular neuropathy affecting all 4 limbs. Diagnosis, 34-year-old patient who presented with descending type of quadriparesis with proximal involvement more than distal with bulbar palsy is a case of acute motor axonal neuropathy, a variant of Guillain-Barré syndrome. Treatment. On admission, she developed respiratory distress. She was intubated and put to ventilator. Rice tube was inserted. Central line was established. Patient was catheterized. IVIG at the dose of 0.4 milligram per kg 5 times a day for 10 days was initiated. Pantoprazole MSET was given. She was advised for physiotherapy and change of positions every 2 hours. After 10 days of admission, tracheostomy was done and catheter was changed after every 15 days. Outcome. After 47 days in hospital, she was discharged. At the time of discharge, neck holding was present. SpO2 on room air was 98%. She was able to speak. Tone was normal. Power bilaterally at upper limb was 3/5 and at lower limb, at hip and knee, the power was 3/5 and ankle, it was 4/5. Reflexes were normal. Literature. Guillain-Barré syndrome is one of the most common causes of acute flaccid paralysis. The variants of GBS includes acute inflammatory demyelinating polyneuropathy, acute motor axonal neuropathy, acute motor sensory axonal neuropathy, Miller-Fisher syndrome. The pathogenesis of Aman variant is include that a membrane attack complex is formed at the nodes of Ranvier and there is loss of sodium gated voltage channels, and as a result there is axonal degeneration. The antibodies usually found in this case is GD1 and GM1. In such variants, albuminocytological dissociation may not be seen. Prognosis. Patient with significant proximal weakness and axonal damage have a poor prognosis. What makes this case atypical? Incidence rate of GBS is 1 or 2 per 100,000 population, and only about 20% of the total cases are diagnosed as Aman variant of GBS. Paralysis is usually ascending and lower limb involvement is more than the upper limb involvement. Facial diaparesis is more common than bulbar palsy, and only 5% of these cases progresses to the total motor paralysis with respiratory failure. These are the references. Thank you.
Why this case is not a case of poliomyelitis?
Ma'am, poliomyelitis is usually common in pediatric age group, and along with that, there is in poliomyelitis there is ascending type of paralysis. Here it was descending type of paralysis.
In GBS also you get ascending paralysis only.
Yes, ma'am.
This is a variant, right?
Yes, ma'am.
Okay. What is your idea when there was a recent GBS outbreak which was there? Do you know anything about it?
Ma'am, it was in Pune, and a nearby reservoir was contaminated.
So what were the manifestations in those patients?
Ma'am, I'm not aware of.
Okay. What is the prognosis in GBS?
Ma'am, usually 95% of them have a good prognosis. However, some patients may land up to CIDP, and patients who require ventilatory support have again a poorer prognosis. And this case where there was quadriparesis has again a poor prognosis. And other syndromes like Aman variant and Amsan variant, and along with Miller-Fisher variant, has a poorer prognosis as compared to AIDP.
What was the therapeutic management in this patient?
IVIG was given at 0.4 milligram per kg for 10 days, 5 times.
What is the role of plasmapheresis?
Sir, various studies has recorded that IVIG and plasmapheresis both have equal efficacy. However, plasmapheresis being a more invasive method, IVIG is better than plasmapheresis.
What is the role of steroids in this treatment?
Steroids as alone cannot be given. It has no significant role in management of GBS, but it could be given as an add-on drug. But individual drug has no role in this.
How do you monitor the patient regularly if he is admitted in your ward? What are the things you are going to do?
Ma'am, we do spirometry because they can have respiratory depression.
Clinical bedside examination.
Ma'am, detailed neurological examination. Then
the central nervous system was normal.
Ma'am, we can do also throat examination because diphtheric polyneuropathy can also present in a similar way.
What about the breath count which we do at bedside?
Yes, ma'am. It could.
Does it give you some information? Because the most dreaded complication would be a respiratory failure in this patient. So that is why you have to keep on monitoring the respiratory part of it. Because your patient had a normal respiratory rate all the time. So it is very important you monitor them like that.
Ma'am, at the same time, we should also monitor BP because it may also present as pan dysautonomia.
Yes, sometimes there may be the autonomic nervous system affected along with this.
What is the other name of this syndrome?
GBS syndrome?
Yes.
Sir, AIDP?
Chinese paralytic syndrome.
Sorry.
And if you see the patients, how they develop, how you stage this disease?
Sir, staging is based on Bridgeton criteria, whether there is clinical evidence or there are points that that does not resemble GBS and laboratory support.
Okay, thank you.
Thank you, sir.
Thank you, participant 9, for your valuable contribution. Next, we welcome participant 10.
Good afternoon, everyone. Today I am presenting a case titled Progressive Breathlessness in a Young Woman When Asthma Was Not the Answer. The patient profile is, the name is Ms. Dolores. She is a 22-year-old female, undergraduate student, Roman Catholic of religion, residence in Urban, and the date of admission was 28 September 2025. The informant is patient herself. The chief complaint presenting was progressive breathlessness 8 months prior to consultation, dry cough 2 months prior to consultation, hoarseness of voice 2 months prior. The history of present illness: the patient was asymptomatic 8 months prior when she began experiencing mild exertion dyspnea while climbing stairs. Over subsequent months, breathlessness gradually worsened, eventually limiting her daily activities such as walking short distances and speaking continuously. During the past 2 months, breathlessness progressed to occur at rest, developed intermittent dry cough without sputum, noticed progressive hoarseness of voice, no nocturnal worsening, no episodic nature, no relief from bronchodilators were noticed. She sought treatment multiple times and was diagnosed with bronchial asthma at her peripheral center based purely on dyspnea and cough. She received inhaled salbutamol and inhaled corticosteroids, a short course of oral steroids. Despite adherence, the symptoms worsened. This is the timeline prior to consultation. At the beginning, 8 months prior, she started noticing these symptoms, which kept on getting worse. And 2 months prior, hoarseness of her voice was also added, and cough was also added. And now she's here for the consult. Negative history: no inhibition, no neck trauma, no previous surgery, no tuberculosis exposure, no GERD syndrome, no hemoptysis, no symptomatic symptoms, no autoimmune disease history, no weight loss, and no allergies. During the physical exam, she was conscious, oriented, and mildly anxious. No cyanosis, clubbing, or lymphoedema was noticed. Her vitals were normal, and in her respiratory system, audible inspiratory striae over the neck was observed. No wheezes, normal ventricular breathing sounds. In ENT, hoarseness was present, no oral lesions were observed, and other systems were unremarkable. Initial diagnostic dilemma was that the patient was labeled as asthmatic despite presence of no wheezer, no episodic symptoms, no bronchodilator response, and worsening symptoms. This triggered a reconsideration. The lab results were conducted. CBC was normal, CRP was normal, chest X-ray was normal. During the in spirometry, flat inhibitory loop was observed. Next CT showed subgluteal circumferential narrowing, and laryngoscopy showed isolated subgluteal stenosis. Spirometric interpretation: this flattened inspirational limb, variable extrathoracic airway obstruction, suggesting a lesion over the thoracic inlet, and no asthmatic patterns. The first differential diagnosis was bronchial asthma, as she was misdiagnosed. It was considered due to progressive breathlessness, dry cough, her young age, and initial treatment was given to her. We can rule it out based on no expiratory vision on auscultation. Breathlessness was persistent and not episodic. No nocturnal variation, no response to bronchodilators or steroids. The spirometry did not show obstructive expiratory pattern. The presence of inspiratory striae is not a feature of asthma. vocal cord dysfunction. It was considered due to inspiratory stire, the breathlessness without lung findings, and she's a young female. Ruling out, lyroscopy showed normal vocal cord movements, obstruction located below the vocal cords, subglottis, and the symptoms were progressive, whereas vocal cord dysfunction are episodic. Tracheal tumor, it was considered because of progressing airway obstruction. As the tumor grows, it worsened. Stire was noticed and non-response to the asthmatic therapy. It was ruled out as the CT showed smooth circumferential narrowing and not a focal mass. No weight loss was observed. The laryngoscopy revealed fibrotic stenosis and not a lesion. Another less likely differential diagnosis was post-incubation subgluteal stenosis, which is the most common cause of subgluteal stenosis and also presents with the main symptoms such as stire and progressive dyspnea, but there was no history of any previous hospitalization. Another variation, another type of subgluteal stenosis is an autoimmune, but it is less likely seen in young it was considered as it is seen in young year and ruled out as no systemic symptoms were noticed and normal ESR, no nasal lesion were observed and no multi-system involvement. The final diagnosis that was concluded was idiopathic subgluteal stenosis based on the exclusion of all secondary symptoms, secondary causes, symptoms and labs. As it presented with stire, fibrotic narrowing of the subgluteus and upper respiratory blockage, upper respiratory obstruction. The management was done by endoscopic balloon dilation, intralesion steroid injection, and airway. And the objective was to restore air volume. After the scheduled surgery, she felt immediate relief from dyspnea. The stire was restored, her voice improved, and discharged when she was stabled. This is the complete timeline. In conclusion, this case highlights how careful clinical examination and physiological intervention can be masquerading as bronchial asthma, preventing prolonged mismanagement. Thank you.
What is wheeze and what is stridor?
Wheeze is an abnormal breathing sound formed at the lower respiratory tract, and it is described as a flute-like or a whistle-like sound, whereas stire is a sound produced at the upper respiratory tract over the neck, near the neck region, and it is described as a monotonous loud sound.
The major difference is one is expiratory, other is inspiratory. So that should give you the clinical clue that when you are getting an inspiratory sound, you should not think of asthma, but you should think of some other causes in this patient.
Yes.
Okay. What was the cause of this stenosis in this patient?
All possible causes such as acquired autoimmune or congenital were ruled out. So it was idiopathic subgluteal stenosis.
So whatever the management was given, is it going to give a permanent relief to the patient?
The surgery, the management that was given provide instant relief, but idiopathic subgluteal stenosis has a high recurrence rate, so surveillance by ENT is required for her.
What are other common causes of recurrent respiratory, means patient coming again and again with the respiratory complaint? Because 2D echo was somewhere not mentioned, because that is something also you should take into consideration.
Pardon?
The cardiac problem also should be taken into consideration when the patient is coming with recurrent breathlessness, when you have no other cause.
Very common complaints regarding breathlessness are such as COPD or heart failure, but no such symptoms that are classic to those diseases were found in this patient.
What is Cotton-Mayer grading? What is Cotton-Mayer grading for subglutic stenosis?
Cotton-Mayer grading is a grading system which goes from 1 to 4, which says grade 1 is narrowing of less than 50%, then grade 2 is 50 to 75%, grade 3 is from 75 to 99%, and at grade 4 no lumen space is found.
Madam is asked what is the commonest cause of this subglutic stenosis?
The most common cause of subgluteal stenosis is acquired, which is caused
Congenital is not commonest cause?
It is not as common as, the most common is acquired. Acquired by a trauma, infection and incubation.
But a book has written congenital is the commonest. Okay, thank you.
Thank you.
As we conclude case presentation in Inferno, I extend my sincere gratitude to our judges for their invaluable guidance and to all the participants for their insightful, well-reasoned presentation that truly reflected clinical excellence. The enthusiasm and academic spirit displayed today made this event a great success. The results will be announced shortly, and I request everyone to remain attentive. Thank you all for your participation and cooperation.
As we conclude today's presentations, I want to express my sincere appreciation to every participant. You have brought unique perspectives to this stage, demonstrating not only your medical expertise, but your profound commitment to the future of patient care.
Every presentation serves as a benchmark for excellence in preparation, and I am certain we have all gained valuable insight today.
I would request the judges to come on stage and share a few words.
कभी बोलेंगे कभी बोलेंगे
Lunch is delayed.
इसको भी मैक्सिमम P4 कितना है?
Just do not announce lunch right now. We tell you.
P4 मुझे नहीं लगता सर P4 इसके नीचे
Please give a huge round of applause for our judges. If you all could share a few words about today's presentation.
So from good morning to good afternoon now. So good afternoon everybody. It's a nice program for the student, and all the students and faculties and seniors are here to see this program. And it was 2 hours long, very long program. Everybody enjoyed. I hope everybody must have enjoyed. And the students has put forth a lot of hard work, and they mentioned all the good cases for presentation. And we hope that we have judged them properly. But everybody has performed good, but we'll have to give prize some first or second. But I will encourage more students to participate for this program. So their knowledge, by that time they will reach and become resident of a particular subject. They will know how to present and how to publish these things in a publication forum. Thank you.
All the cases which were presented were very good. Most of the thing which I have understood, that more than a clinical diagnosis, the more emphasis was given on investigations, because most of the cases it was difficult to reach the diagnosis unless you have the support of all the infrastructures. So it was a very well performed examination and very nicely put by every candidate. They have taken a lot of efforts to do this presentation. So all the very best for all of them. Thank you.
I would like to request Case Presentation Head Savita Yadav to felicitate Dr. J. Narayan Senapati sir. Now I would like to request Sports Executive Amay Patil sir to felicitate Dr. Shailaja Poddar ma'am.
Now the moment we've all been waiting for, the results of Inferno.
All the participants have done very well. They should not be disheartened by announcing who is first, who is second, and who is third. Everybody has done good, but somebody will do the best on that day. So the first prize goes to participant number 9. The second prize goes to participant number 4. Participant number 4.
Thank you so much, judges, and a hearty congratulations to all our winners and participants. We now move on to the next session and on a topic that speaks to the heart of our future, youth for a purposeful life.
To lead this conversation, we are privileged to welcome a speaker whose own journey is a masterclass in living with intention. Sir is a visionary leader who bridges the gap between high-level strategies and grassroots reality.
A computer engineering graduate from Pune University, he went on to earn his MS in non-profit management from the University of Pennsylvania, where he was honored with the Richard J. Estes Global Citizenship Award for his exceptional social impact.
Since 2008, as the Program Director of Nirman Youth Initiatives, Sir has been a catalyst for the youth leadership across India. As the Joint Director of Research, he has been instrumental in public health research within the tribal and the rural communities of Gadchiroli.
He is currently helping shape the future of our nation's youth as a member of the National Education Policy Implementation Steering Committee for the Government of Maharashtra. Sir does not just talk about a purposeful life, he embodies it. Ladies and gentlemen, to awaken our sense of purpose, please welcome Mr. Amrut Bang, sir.
Good afternoon, everyone. I'm sorry to ruin your lunch. My name is Amrut. I'm coming all the way from the other corner of Maharashtra, from a place called Gadchiroli. And I thank the management committee of Rajiv Gandhi Medical College and your event coordinator Himanshu for inviting me at Zenith and for giving me this opportunity to interact with you all. Just a quick check. Am I audible at the back? Okay. And which language would be most comfortable? Marathi, Hindi, English? Pardon? Okay. Is there anybody in this hall who doesn't understand Marathi? If yes, can you please raise your hands? Anybody who doesn't understand Marathi? Okay, there are a few. Okay, nice. So I'll try to switch in all three languages. Marathi is my mother tongue. I obviously know Hindi. And English is something that we all are comfortable with. So I'll try to converse between all three. So yeah, the topic of my today's session with you is Youth for Purposeful Life, which is also the tagline of the program that I lead called Nirman. Before I begin, let me share with you 4 quick stories. In fact, not stories, just the initial part of the story. So we'll start with Dr. Amit Patidar, who comes from a place called Mandsaur in Madhya Pradesh. Now, Amit is a brilliant, hardworking student. He did his MBBS from AIIMS Rishikesh. Then he got selected to do MS in surgery at AIIMS Delhi, supposedly the best medical college in the country. And then he graduated from AIIMS Delhi with his MS in surgery and was the topper of his outgoing class. So in terms of what a medical student would like to achieve, he has probably achieved most of the stuff. And he has now options open. Like many of his MS classmates, he could just go out of this country. He could also join some big fat paycheck giving corporate hospital in Delhi or Mumbai or Bhopal, anywhere. He could also just stick back at MS, at AIIMS and do a SRship or something like that. Or he could do something else. He didn't know what to do next. He's searching for his answer. That's story 1. Story 2 is Ojas Krishnani, who is from Raipur, Chhattisgarh, but graduated from Seth GS Medical College, KM, and was the topper of his class, also awarded the best outgoing student of KM. In his first attempt, he had also cracked NEET. His parents, both of them doctors, have their roaring practice in Raipur. They wanted the prince to come back and take it over. But Ojas doesn't want to go back. Ojas is passionate about the issue of addiction, but is contemplating what to do next. Third example, Dr. Arti Gorwadkar. Arti hails from Nasik, did her MBBS from BJ Medical College, Pune. Her sole dream while going for her MBBS training at BJ was, I want to finish my MBBS and then migrate to the US. That was the goal with which she went for her MBBS training. But by the time she came to her internship, she was quite disillusioned. And in her internship, when for the first time she saw patients from up close, she was involved in providing care to them, and she saw the abysmal state of healthcare. She was quite shattered. And she felt that when the healthcare in my country is so bad, should I be just running away? That's her question. And finally, the fourth question is my own question. I graduated as a computer engineer in 2007. I was fortunate enough to get 13 placement offers. I was also the topper of my class when I graduated. And I took my job in a company called Symantec. Some of you might have known the company. They produce Norton antivirus. So I used to work there. At that point in time, Symantec was the fourth largest software multinational in the world. I was through the first year of my job, and I was also quite restless because for a computer engineer, whatever tick marks were there, I had achieved all of them. But I couldn't see any meaning, any purpose in what I was doing at Symantec. I was sitting in Pune trying to write software code to make banking transactions safe and secure for some gentleman in the US whom I was never going to see in my life. So after the initial nasha of getting a big corporate world and having a fat salary coming your own way, after that initial nasha was over in a few months, I was left contemplating what am I doing with my life. I deliberately told you these 4 stories. What happened to the initial 3, I will tell in the later half of my talk. But if you could see, there is a commonality in all the 4 stories. Each of them, so to say, got tremendous amount of information in their undergrad, like all of you. If you are lucky a college graduate in India, you sometimes also get skills. Sadly, most of us do not get them. That's why a fresh MBBS doctor is quite shaky when it comes to doing something on his or her own. ब्रिटिशों के ज़माने में एमबीबीएस डॉक्टर सिविल सर्जन के रूप में काम किया करते थे. आज के एमबीबीएस डॉक्टर को थियरी आती है लेकिन स्नेक बाइट नहीं आता, थियरी आती है लेकिन मलेरिया ट्रीट करना नहीं आता. आज के कंप्यूटर ग्रेजुएट को बग फ्री कोड लिखना नहीं आता. आज के कॉमर्स ग्रेजुएट को थियरी आती है लेकिन बैलेंस शीट रीड करना नहीं आता. और आज के फ्रेश जर्नलिस्ट को थियरी आती है लेकिन इस इवेंट का फैक्चुअली करेक्ट, ग्रामेटिकली करेक्ट रिपोर्टिंग कर बोला तो वो नहीं आता. सो in India, if you look at young people, information everybody has got. Skills, some of us have got. But most of us do not have answer to this question. What is my larger purpose? What am I supposed to do in my life with the information and skills that I have received? And I just gave you 4 examples of how does that purpose question actually look like in your life. Maybe at your age, you are too busy with the day-to-day of the college. And that's why we do not engage with this bigger question that awaits each one of us, कि ये सबके बाद करना क्या है. यूजी है, पीजी है, कोई सुपर स्पेशलिटी है, वो सब कभी ना कभी तो खत्म हो जाएगा. मेडिकल में थोड़ा ज़्यादा लंबा चलता है जर्नी, इंजीनियरिंग या बाकी ब्रांचेस में इतना लंबा नहीं चलता है, लेकिन मेडिकल में भी 30-32 तक तो आपका सभी हो जाएगा. उसके बाद कभी तो भी जिंदगी नाम की चीज़ चालू होगी. एंड द बिगर क्वेश्चन इज व्हाट डू आई डू इन दैट. नो, इट्स नॉट एज इफ यू आर हेल्पलेस. इट्स नॉट एज इफ आप रोजगार हमी योजना के ऊपर का कोई मजदूर हो कि कल क्या करूं मुझे पता नहीं, कहीं से तो भी खाना चाहिए. यू आर रियली प्रिविलेज्ड to be studying in a government medical college and doing MBBS. You are one of the most privileged students in this country. लेकिन मैं करूं क्या आगे, इस सवाल का जवाब मिलता नहीं है. When I saw that this was the situation both in my life and also in the lives of so many others, I decided to quit my job in 2008. And since then, for the past how many years? 18 years. I shifted my base from Pune to Gadchiroli, which, as you may know, is a district in Maharashtra. It's a remote, tribal-dominated district on the easternmost corner of Maharashtra. मेरे घर से 60 किलोमीटर पे छत्तीसगढ़ का बाउंड्री है और नीचे तेलंगाना का बाउंड्री है. So it's one of the farthest place from Bombay, but in the same state. I shifted there and I started this youth program called Nirman. So this is how you would usually find me with a group of around 60, 70 young people every month coming from all over the country, who are also in search of answering this question, what's my larger purpose? While I do this Nirman program, I work with this social organization called Search, which was started fortunately by my parents, Dr. Abhay and Dr. Rani Bang, who are quite well known across the country, across the globe for their pioneering contributions to healthcare. So Search is the parent NGO, and we do a lot of health work. And in addition to a variety of health work that we do, the youth program which I lead is Nirman. So in Search, we do quite a few things. I'm not going to bore you with all of them. But just to tell you, these are quite a few accolades which we have received in the past. WHO calls us Public Health Champion. Time magazine calls us Global Health Heroes. A few years ago, India's president awarded our founders with Padma Shri. So that's okay. That's for some of the good work that we have done. But when we went to this place in 1990, when my parents went to this place in Gadchiroli, so we have a 45-acre campus now where I live and operate, where 150 of us live and operate. And I'm at the end of my talk, I'm going to request all of you to come visit us sometime. When we went there in 1990, the place looked like this. It was barren. Now if you come to our place, it looks like this. So on that 45-acre campus, we now have around 16,000 trees which we have planted. We have more than 100 species of birds. And this is the entire campus. This is where I live, by the way. This is my house here. That's our hospital, if you look at right there. This is also one of our lakes. So it's our personalized swimming pool, if you want to say that. So this is where we stay and operate. This is also some glimpses of the campus. So just to say, मैंने कोई त्याग वाग नहीं किया है मेरी जिंदगी में. I live a beautiful life, a life that I love. My daily commute time is 2 minutes by walk. I get to eat lunch when my son comes back from school with him. So ये कोई त्याग वाग मैंने किया ऐसा मुझे लगता नहीं है. But this is just a person's journey and so many other young people's journey to truly value what they value, not just be driven by conventional norms, and find out what gives them meaning and purpose. Okay? So इसीलिए ये इनिशिएटिव हमने चालू किया, जिसका नाम जैसे मैंने आपको कहा है निर्माण. Now इसमें हम क्या अलग अलग चीजें करते हैं वो तो मैं आपको धीरे धीरे बताऊंगा ही. Before that, one question. If you look at that banyan tree, just by looking at the tree, what do you think? Is the tree flourishing or is the tree in a bad shape? It's flourishing, right? काफी फला फूल है, greenery से भरा हुआ है. So if we look at a tree, we can identify whether the tree is doing well or not. But if we look at a young person, how can we decide whether a young person is really doing well in his or her own life? I have a son whose name is Arjun. Now Arjun is 5.5 years of age. Since the time Arjun was born, there are milestones in pediatrics and in child psychology on the basis of which I can decide whether Arjun or for that matter any other child is growing healthily or not. वो ममा के दूध से सॉलिड फूड पे कब शिफ्ट होगा, वो रेंगने कब लगेगा, वो चलने कब लगेगा, वो छोटी छोटी बात कब करने लगेगा. फॉर एवरीथिंग वी हैव ग्रोथ माइलस्टोन्स. You can compare Arjun or any other child's growth against those milestones. If everything is going on well, celebrate. If not, take corrective measures. बराबर है? ये छोटे बच्चे के लिए है. और इसी के आधार पे हमें ये भी पता है कि as per National Family Health Service data, 35% of Indian children are malnourished, which is a serious problem. And we know that child malnutrition, although it has come down in recent years from percent to 35%, there is still a long way to go. But if this all exists for children, what about the youth? We all give lip service to the fact that India is a youth country, young people are our demographic dividend, this, that. लेकिन यूथ की तरफ देखने का गवर्नमेंट का नजरिया होता है एज अ बेनिफिशियरी और एज अ वोटर. हमें वोट चाहिए या हमारी किसी स्कीम के आप लाभार्थी हो. प्राइवेट सेक्टर का नजरिया होता है दैट यूथ आर पोटेंशियल कस्टमर्स, इनको कुछ तो भी बेचना है. बट यूथ आर वर्दी ऑफ लव, अटेंशन, केयर एंड ऑफ ब्लॉसमिंग इनटू अ फुलर सेल्फ. इस तरीके से यूथ की तरफ देखना यूजुअली हमारे सोसाइटी में कोई करता नहीं है. And that's why we don't even know the answer to this question, are our young people flourishing or not? आप खुद का ही देख लो. आजू बाजू अगर कोई भी आपको पूछेगा तू क्या कर रहे हो, और अगर आप बोल दो कि मैं राजीव गांधी मेडिकल कॉलेज करवा में एमबीबीएस कर रहा हूं, लोग बोलेंगे लाइफ सेट है यार तेरी. एज इफ आपको गवर्नमेंट मेडिकल कॉलेज में एमबीबीएस के लिए एडमिशन मिल गया, हो गया मक्का, अब आगे कोई जरूरत ही नहीं है. लेकिन किसे पता आपके जीवन में बाकी भी 4-5 कुछ चीजें होगी. बट नोबडी सीम्स टू बॉदर अबाउट इट. वी ओनली मेजर यंग पीपल्स सक्सेस इन लाइफ on the basis of the marks that they have achieved, the placement package that they have received, the degrees that they have, square feet of purchase property they have, or amount of bank balance they have, और vehicles they have. ज़्यादा से ज़्यादा शादी हो गई क्या? इससे ज़्यादा एज इफ यंग लोगों के लाइफ को कुछ है ही नहीं. When we saw this, we were quite upset. So we thought if we are committed to young people's well-being, we should find out what does a young person's well-being, in technical terms it is called flourishing. What young people's well-being or flourishing look like? Surprise, surprise. I thought somebody must have answered this question in literature. So I went around looking for literature. I found nothing. India has 26 crore young people in the age group of 18 to 29. Our youth demographic alone is larger than the combined population of England, Germany, and Austria. But nobody had even bothered to ask this question, what does a flourishing youth look like? What are the various dimensions to it? जब किसी के पास जवाब नहीं था तो मुझे लगा यार अपने को ही कुछ करना पड़ेगा. So based on whatever scientific training that I had, based on my interactions with my professors in the US, and based on thousands of young people with whom we had worked in Nirman, we came up with our own framework of youth flourishing. How do we assess if a young person is really doing well in his or her life? How do we assess that? We will assess that young person's well-being on the basis of 7 different domains. Physical health, साइकोलॉजिकल वेलबींग, कैरेक्टर डेवलपमेंट, सिर्फ पर्सनैलिटी डेवलपमेंट नहीं, पर्सनैलिटी बाहर की पुताई है, अंदर का मटेरियल कैरेक्टर है. सोशल रिलेशनशिप्स, प्रोफेशनल डेवलपमेंट, लाइफ स्किल्स एंड सोशल कंट्रीब्यूशन. ये 7 डोमेन्स, और 7 डोमेन्स में मिलके लगभग 50 फीचर्स हैं. उसके आधार पे वी डेवलप्ड फर्स्ट ऑफ इट्स काइंड साइंटिफिक फ्रेमवर्क of what does a flourishing youth look like. After the framework, we went ahead and developed first of its kind questionnaire called the Nirman Youth Flourishing Questionnaire. क्योंकि आपको पता चलना चाहिए ना whether you are really doing well or not. So we developed this flourishing questionnaire where there are 7 domains and 50 different indicators. So you can assess whether you are really doing well in your life or not, whether you are really flourishing as a youth or not, scientifically on a 7 domain 50 question framework. And sadly, I'm sad to share this, but sadly, what did we find? More than 5,000 youth, the first of its kind research done in India, we tried to find out what is the status of young people's development and well-being. What we found was, you remember there are 7 domains? True? So, if you are doing well in all the 7 domains, that is great. You are flourishing in all 7 domains. The opposite of flourishing is called languishing. That's the technical term, called languishing, which means you are not doing well. So percentage of young people who were doing badly, who were languishing in either one or more of the 7 domains, that was 81%. 81% of the youth were doing bad in one or more. So we could call it total youth malnutrition. And if you want to look at severely malnourished youth, we gave a breakup that if you are doing bad in 4 or more of the 7 domains, that means the condition is really serious. That percent was 42%. So while India child malnutrition, which is 35%, that takes such a big media space, which it should. Youth malnutrition is now an even worse and bigger problem for this country, with 42% of the youth being severely malnourished and 81% were being malnourished in at least one or more of the 7 domains. We're quite shocked by these findings. In the last 2 years, I presented this framework and the findings in US, Austria, and Australia. Last July, I was in the World Congress of Positive Psychology in Australia, where I presented this. The framework and the findings were received very well at all the 3 places, because for the first time in the history, somebody had talked about the status of flourishing and well-being of Indian youth in a scientific manner. But it's really sad that such a high percent, it should be 81%, not 83, such a high percent of youth are languishing is really alarming, and it calls for immediate attention. You understand? Now, in case you are also interested in finding out where you are in this flourishing journey, you could just scan the QR code. Can you scan it from that distance? Can you? Just take it out. I don't know how much time do we have, but at least if you scan it and open it up in your mobile, maybe you could fill it up later on also. It won't take you more than 15 to 20 minutes. But maybe this is not the best place to do it right now, because we may spend 20 minutes right now. Is it opening up? Is the questionnaire opening up? My flourishing index. Great. So can you do this one thing for me? Tonight, before you sleep, can you take this? And it will give you a 5-page report in your mailbox. It will give you a 5-page report in your mailbox, which will talk about your flourishing status. So you'll get a 5-page report in your mailbox on all the 7 domains and in the 50 different indicators. Where are you? How well are you doing? You'll get to know all of that in it. So can I take this as a promise from you that by tonight, before you sleep, you would have filled the questionnaire? Let's see what's the status with Rajiv Gandhi Medical College students. Just one thing, do not bluff. Because that's not going to serve anybody any value. This is not about passing any judgment. This is about you truly discovering what is your status of flourishing. Because only when, if you have a thermometer, the purpose of thermometer is to diagnose whether you have fever or not. If you put it in ice and say that, hey, I've got no fever, that is not going to help anyone. You realize it? Okay, so go ahead and do it. And you'll get your own scores. You'll also get domain-wise scores. You'll also figure out by the end of the report how many domains you are flourishing in, how many domains you are not flourishing in. You'll also be able to see some of the questions. There are 50 different questions. So you'll be able to see some of them. You could figure out what are particular questions in which you are not doing well. What are some of the questions where you are doing well? The questions where you are not doing well, you could think about improving. Okay? So this kind of gives you a roadmap for your own development. I'm part of the NEP, the National Education Policy Committee. NEP talks about holistic development and well-being of students. Great. But nobody knows the answer to this question. मतलब क्या? होलिस्टिक डेवलपमेंट वगैरह सुनने में बड़ा अच्छा लगता है, लेकिन अगर किसी ने सवाल पूछा होलिस्टिक डेवलपमेंट, वेरी गुड, व्हाट डू यू मीन बाय दैट? Unfortunately, nobody had an answer. This is for the first time our country is getting a science-based answer as to what will flourishing of our youth look like. So please go ahead, it's completely free, make use of it and use it for your own development. If you like it, if you like your report, share the link of the questionnaire with other people that you know so that they will also come to know where are they doing well, where are they lacking. Okay? Then you could figure out what are some of the steps that you could take to improve. Suppose your score tells you that you are really flourishing. Suppose it tells you that you are flourishing in certain domains, may not be flourishing in some XYZ domains. Obviously, you need to take some corrective measures. Great. लेकिन आप flourish होने लगे, मान लीजिए, is that enough? Is that enough? When do we say that a tree is truly flourishing? When the tree is growing up, it takes resources from the environment, from the atmosphere, from the soil. But when the tree has grown up, when the tree has flourished, what does it start doing? Starts giving back. वो ऑक्सीजन देना चालू करेगा, पंछियों के लिए छाया देना चालू करेगा, नीचे से कोई पथिक जा रहा है उसे छाया देना चालू करेगा, फल फूल देना चालू करेगा, बायोडाइवर्सिटी में मदद करेगा, बारिश के लिए मदद करेगा, जो कार्बन हम सब लोग फेंक रहे हैं हवा में उसको सिक्वेस्टर करने में मदद करेगा. बराबर है? So only when I start giving back, that is the true test of am I really flourishing or not. कुछ तो ऑब्वियस मुझे मेरे बीच के अंदर की जो कुछ खामियां हैं उनके ऊपर काम करना पड़ेगा. But the ultimate test is, am I only receiving or have I started contributing back? तो इसलिए निर्माण प्रोग्राम में हमने कोशिश ये की कि first thing, how do we help young people flourish? But then that's not enough. That's well begun, but not well done. How do we also inspire young people so that they can take on a variety of issues that they see around themselves? How can we help them find a purpose that is a direction giving thing for their own lives and they can do something meaningful? That was the next challenge that we came to. And as part of the Nirman program that I lead, we do variety of activities. I am not going to bore you to death with telling details of all of them. You could just check our website, nirman.mksil.org, or just Google Nirman Amrut Bang. You will be able to find out all these details. But we do variety of activities so that young people get this chance to flourish, but then not just stop at it, but go ahead one step. Answer questions like the ones which Dr. Amit, Dr. Ojas, and Dr. Aarti were met with, and do something purposeful in their lives. Over the years, as part of our flagship program, which is a series of residential training workshops which we do on that beautiful campus which I showed you. So every month, we have a new workshop coming in where people from across the country apply and they go through that 5-day training workshop. We fortunately also have a MOU with your medical university, which is MUHS, and MUHS has very clearly stated that whichever medical student gets selected for Nirman should be given a 5 days leave from the institute. Okay, so we already have that MOU with MUHS, and we get students from across the country to take part in this program. Just to see few names of the institutes that people come from, and I'm very happy to be here today because next time I present in whichever institute, whichever place, I would like to see Rajiv Gandhi Medical College name in that. Is that a promise? That depends on you, not on me. So is that a promise? Okay, good. So you also meet with variety of such resource persons coming from across the country who come and become part of these workshops to interact with you. Various things that we do in the workshop. It's a 5-day workshop, I told you, that happens on that campus, where we deal with variety of things which are of value to a young person's life. What are my values? And how do I develop a solid relationship with a mentor? How do I go about finding my purpose? How do I develop a good reading habit? What's my relationship with money, youth, and substance use? Because for young people who do not have a strong purpose, जिनको जिंदगी नशा नहीं देती है, वो नशे के पीछे जाते हैं. अगर आपकी जिंदगी में सॉलिड इनफ पर्पस है, तो भाड़े की नशा करने की जरूरत नहीं पड़ती है. तो ये सरप्राइजिंग चीज है कि मेडिकल कॉलेज के स्टूडेंट्स का भारत भर के ये क्यों एक ड्रीम होता है कि सेकंड ईयर या थर्ड ईयर में सितंबर महीने में हम एम्स दिल्ली जाएंगे और वहां पे पल्स देखेंगे जहां पे नशा ही नशा है. Not just that it is scientifically stupid. Not just that it is scientifically stupid. People who refuse COVID vaccine and people who drink alcohol are equally stupid. Why? I am not saying this just as a moralistic stance. By the way, I did not tell you a funny thing about me. Probably I did not mention that in my introduction. One of the things that I am most proud about is that when I was in third standard, I went to jail. And I'm very proud about it. हाँ, ताली बजा लो, फिर बताता हूं क्यों गया. क्यों गया? The district that I belong to, which is Gadchiroli, there was a mass public movement in our district कि alcohol नहीं चाहिए. There was a mass public movement. Alcohol was legally allowed in the district. तो हमारे यहाँ के public ने सोचा कि alcohol नहीं चाहिए. My parents were one of the leaders of that movement. Both of them are doctors. My father is an MD medicine. My mom is a gynecologist. But they were approached by the local community कि आप इस movement का नेतृत्व कीजिए. So they were leading the movement. And as the movement built up, one day the people of Gadchiroli decided कि हम आज से गढ़चिरौली में जनता की दारूबंदी घोषित कर रहे हैं. सरकार को क्या करना है करो. बंबई में बैठ के सरकार नहीं डिसाइड कर सकती कि गढ़चिरौली में दारू बिकेगी कि नहीं. गढ़चिरौली में दारू बिकेगी कि नहीं, ये निर्णय किसने लेना चाहिए? किसने लेना चाहिए? गढ़चिरौली के लोगों ने लेना चाहिए. वहां से 1000 किलोमीटर दूर बंबई में बैठी सरकार कैसे डिसाइड कर सकती है? तो गढ़चिरौली के लोगों ने बोला जनता की दारूबंदी हम घोषित करने वाले हैं. देयर वाज अ मास मोर्चा फॉर दैट. माय पेरेंट्स वर लीडिंग इट. Me and my elder brother is a doctor. He's 5 years elder to me. तब वो भी 8वीं में था, मैं शायद से 3री में था. हम दो भी साथ में थे. और उसी वक्त my grandfather had also come. Now my grandfather was a disciple of Mahatma Gandhi and Vinoba Bhave. He was a freedom fighter. और जब हमारा देश आज़ाद नहीं था, so he had gone to jail for 3 years in our freedom movement. बाद में जब इमरजेंसी आई थी तब भी वो 1 साल जेल में थे. तो मुझे हमेशा लगता था यार अपना दादा जेल में जाके आया, साला अपन ने जिंदगी में कुछ नहीं किया. तो वो दैट वाज द ओकेजन व्हेन 3 generations of our family were together. My grandfather, my parents, me and my elder brother. And because we were part of that huge morcha, police arrested us and took us to jail. Going to jail with 3 generations of my family together for the cause कि हमारे district में दारू नहीं चाहिए is undoubtedly the proudest moment of my life. And I'm extremely happy to tell you that we got it done. In 1994, Sharad Pawar was the chief minister at that point in time. Sharad Pawar ultimately signed it as the chief minister. In 1994, Gadchiroli district legally became alcohol free. And since 1994 till now, कितने साल हो गए? 31 साल हो गए. हमारे जिले में दारू नहीं है. तो I definitely come from this kind of a mindset. But in addition to this, you are all medical students. So you should also believe in science. Now, what does the science tell us about science tell us about alcohol? So let me tell you, this is a quick detour, but I'll come back to my original topic. But let me just explain this. Homo sapiens have been on Earth for at least 3 lakh years. In the entire history of Homo sapiens on the planet Earth, the largest medical study ever done, is called Global Burden of Diseases Study, GBD. Global Burden of Diseases Study, GBD, is the last word in medicine. This is the Makkah of medicine. what your textbooks say is not the last word, because textbooks are by definition old. Do you understand that? Textbooks never contain the latest science. कल क्या discover हुआ है, ये तुम्हारे textbook में है क्या? So textbooks are by definition old. Keep that in mind. So the latest word in medical sciences and the last word in medical sciences is GBD. Now the global burden of diseases study has very categorically told us that the safest limit of drinking alcohol is 0. तो ये जो गधापन होता है ना, अरे थोड़ी सी पिया तो अच्छा रहता है. You know, I have heard red wine is good for heart. ये गावंडा लोग हैं, ये अंधविश्वासु लोग हैं. इनके ऊपर दया करो, इनकी सुनो मत. जो मेडिकल स्टूडेंट दारू पीता है वो गधा है. दिस इज मलेरिया होने के बाद प्लाज्मोडियम से होता है, अपने को पता है, और आप एंटी मलेरियल लोगे. अब ऐसा बोलेगा कि नहीं नहीं नहीं, मलेरिया किसी जादू के कारण हुआ है, हमें मांत्रिक के पास जाना चाहिए, ऐसा बोलोगे? तो वैसा बोलना या कोविड का वैक्सीन न लेना या दारू पीना इज ओके फॉर हेल्थ आर ऑल इक्वली नटोरियसली स्टूपिड. So we need to understand the science behind alcohol, which young people unfortunately do not. And that's why वो जो पल्स वाली बात मैं कर रहा था, वो दोनों तरीके से सैड है मेरे दोस्तों. The obvious sadness is that bright medical students of this country are being unaware of the science of their own field and are drinking alcohol or drinking drugs or making drugs or whatever. That itself is scientifically sad. But I think there is another deeper sadness. And the deeper sadness, which brings me back to our topic, is ऐसा क्यों है कि यूथ को उनकी जिंदगी में कुछ दूसरा पर्पसफुल नहीं है, because of which they have to find thrill in these cheap mediums. So I think it also talks about an existential crisis which many young people have, क्योंकि उनको जिंदगी में बहुत कुछ ऐसा एक्साइटिंग मीनिंगफुल कुछ दिखता ही नहीं है. तो उन्हें कुछ बेचारों को दिखता ही नहीं है, तो कुछ तो भी खींचतान के लेके आओ, तो चलो पल्स. सो दैट इज द डीपर क्राइसिस. इसलिए निर्माण में हम जो कोशिश कर रहे हैं वो कोशिश ये कर रहे हैं कि हाउ कैन वी हेल्प यंग पीपल फाइंड सच काइंड ऑफ अ पर्पस दैट दे वोंट बी सफरिंग थ्रू दिस एग्जिस्टेंशियल एंग्स्ट एंड वॉइड. So these are some of the things that we do as part of those workshops. This is how it would in a standard look like. By the way, just for you to know, वहाँ पे आपको सबसे कॉर्नर का फोटो दिख रहा है क्या? उसमें कुर्सी पे जो बैठा हूँ मैं हूँ. मेरे बाजू एक लड़का दिख रहा है क्या आपको जो प्रेजेंट कर रहा है? वो लड़के का नाम है आदर्श पाल. ही कम्स फ्रॉम सफीपुर इन उत्तर प्रदेश. हमारे निर्माण के 9th बैच का वो मेंबर है. हर साल हमारी एक बैच होती है, साल भर हर महीने वर्कशॉप होते हैं. उस साल के वर्कशॉप्स के सभी कैंडिडेट्स को हम उस बैच के लोग बोलते हैं. नाउ ओवर 16th बैच इज गोइंग ऑन. तो आदर्श इज फ्रॉम आवर 9th बैच. ही इज प्रेजेंटिंग अ बुक, Grapes of Wrath by John Steinbeck. Amazingly beautiful novel. So we do quite a lot of effort in helping promote reading culture in young people. अच्छी रीडिंग करेंगे, अच्छी किताबें पढ़ेंगे, मज़ेदार किताबें पढ़ेंगे तो बाकी फालतू चीज़ें नहीं लगेगी. लेकिन ये आदर्श की एक बात और बता दूं. आदर्श इज प्रेजेंटिंग ग्रेप्स ऑफ रात बाय जॉन स्टाइनबैक. 3 साल पहले की एम्स की मेडिकल एंट्रेंस में, पोस्ट ग्रेजुएट जो मेडिकल एंट्रेंस होती है ना, आदर्श वॉज ऑल इंडिया रैंक 1. तो अभी 1 महीने पहले उसने एम्स दिल्ली से एम्स एमडी मेडिसिन खत्म किया है. ये मैं बस बताना इसके लिए चाहता हूँ कि आपको ऐसा ना लगे कि जिसको कुछ नहीं मिला जिंदगी में, भूले भटके ऐसे लोग जाते हैं निर्माण में. ऐसा नहीं है. पीपल हु आर डूइंग रियली वेल बट हु हैव अ हायर परस्यूट देन दैट, हु आर नॉट जस्ट सेटिस्फाइड बाय जस्ट फिनिशिंग डिग्रीज, दोज आर द काइंड ऑफ पीपल हु कम. एंड दैट्स व्हाई वी हैव अ सिलेक्शन प्रोसेस. Because quite a few people apply to be part of these workshops, but I would be very happy for you all to be also there. These are some of the various institutes with whom we have our partnerships, and you can see MUHS right there. So that's okay. इसको छोड़ देते हैं जरा. You could just read some of the testimonials. What do young people say? many of the people who come to Nirman usually come in their undergrad. So for example, Tanmay जो है ये MBBS कर रहा था तब आया. Right now he is doing MS surgery in Sion Medical College. वहाँ पे अक्षय जो दिख रहा है वो KEM में था undergrad तब आया. Now he has recently finished his MS in ophthalmology from Arvind Eye Care, and he plans to start his own social organization in Nasik from where he comes to provide ophthalmic care to rural areas. So ऐसे तो बहुत सारे लोग आएंगे. हमारा सवाल था यूथ फॉर पर्पसफुल लाइफ. तो वो पर्पस क्यों इंपॉर्टेंट है ये मैं आपको बताया. अभी इश्यू है कि ये जो मेरा पर्पस है, कैन द स्फीयर ऑफ दैट पर्पस गो ऑन एक्सपैंडिंग. पर्पस इज नॉट जस्ट अबाउट मी. जो जस्ट अबाउट मी होता है उसे बोलते हैं हॉबी, जो मैं सिर्फ खुद के मजे के लिए करता हूं. मुझे क्रिकेट खेलना बहुत पसंद है, सचमुच बहुत पसंद है. आई लव स्विमिंग, आई लव रीडिंग. आई रीड यूजुअली 30 to 40 बुक्स अ ईयर. बट दीज थिंग्स आई डू for my own joy. They are my hobbies. Some of you may have a hobby of dancing, some of you may have a hobby of guitar or whatever else. Some may have a hobby of gardening. बहुत अच्छा है hobby होना. But let's not confuse hobby with purpose. Purpose has 3 different components. A, it is about a far horizon aim. Purpose by definition is a far horizon thing. अगर मैं बोल दूं कि मुझे MD मेडिसिन करना है तो ये चीज फार होराइजन है क्या? हाँ या ना? ना, क्योंकि 4-5 साल में ये खत्म हो जाएगी. सो MD मेडिसिन करना कैनॉट बी योर पर्पस. दैट कुड बी अ सुटेबल यूजफुल गोल इन लाइफ टू डू MD मेडिसिन. इट कुड बी अ यूजफुल गोल और somebody else wants to do something else. यूजफुल गोल. बट मुझे जिंदगी में लंबे समय तक क्या करना है, दैट इज माई पर्पस. इट इज बाय डेफिनेशन फार होराइजन. Second, it's your purpose, so obviously it has to be meaningful to you. दूसरे किसी को, आपके सीनियर को, आपके क्लासमेट को, आपके मम्मी पापा को, आपके चाचा को मीनिंगफुल होकर कोई मतलब नहीं है. इट हैज टू बी मीनिंगफुल टू यू. इट्स योर पर्पस. एंड फाइनली द साइंटिफिक डेफिनेशन ऑफ पर्पस बाय इटसेल्फ टेल्स अस दैट पर्पस हैज टू हैव अ कंपोनेंट व्हिच इज बियॉन्ड द सेल्फ. ये मैंने खुद का नहीं डाला है. द वर्ल्ड्स फोरमोस्ट अथॉरिटी ऑन पर्पस, Professor William Damon, who is a professor at Stanford University. So इन्होंने पर्पस के साइंटिफिक डेफिनेशन कॉइन की है और उसमें ये 3 फीचर्स हैं. So this is the globally accepted architecture of purpose, which is going to have 3 different components: far horizon aim, personally meaningful, and third, beyond the self. Otherwise, it's a hobby. Nothing bad in having a hobby. Everybody should have a hobby, but let's not confuse between a hobby and a purpose. Now the issue is, as doctors, as budding doctors, can you go on expanding the perimeter and circumference of your purpose? And when a young person starts living a life of purpose, what does it look like? What does it look like? Just to give you an example, I talked about Amit, you remember? Now Amit had all the options to do after his surgery. But Amit decided that he wants to go and do surgery in a place where there is no surgeon. So Amit is working in a block called Dhanora. It's a tribal block. वो पूरे ब्लॉक में, पूरे तालुका में एक भी दूसरा सर्जन नहीं. Amit is the only surgeon. और वो बंदे ने पिछले 1 साल में 550 सर्जरीज वहां पे की है. तो एम्स का लड़का, एम्स का टॉपर कहीं भी जा सकता था, लेकिन उसने ऐसा सोचा कि मुझे मेरी सर्जरी की स्किल ऐसी जगह पे जाके इस्तेमाल करा के देनी है वेयर देयर इज नोबडी एल्स. लेट्स लुक एट अ फ्यू मोर एग्जांपल्स. दिस इज डॉक्टर सूरज, who graduated from Indira Gandhi Government Medical College, Nagpur. He is a native of Chandrapur district. उसने बोला चंद्रपुर शहर में अभी जीएमसी भी आ गया है, चंद्रपुर शहर में बाकी भी बहुत प्राइवेट हॉस्पिटल्स हैं, वहाँ पे मैं क्या करूँ. बट ही वांटेड टू डू समथिंग फॉर हिज डिस्ट्रिक्ट. सो इन चंद्रपुर district there is a तहसील called सावली in which there is a place called गेवरा बूज. वो गेवरा बूज जो जगह है वहाँ पे काफ़ी सारे आजू बाजू गाँव हैं. वो पूरे सावली तहसील में एक भी MBBS डॉक्टर नहीं है. सूरज went and settled there. He started his own social organization called Sobat Foundation. उसकी वाइफ डॉक्टर जानकी, शी इज अ डेंटिस्ट, शी ऑल्सो जॉइंड हिम देयर. और पिछले 4 सालों में ये कपल ने मिलके लगभग 50,000 पेशेंट कंसल्टेशंस वहां पे किए हैं. That's how a young person with purpose looks like. This is another example. Ashwin. Ashwin is a mechanical engineer, was working in Kirloskar company. Kirloskar is a very well-known mechanical engineering company. Some of you might have heard about them. लेकिन उसको लगता था यार रिच कंपनी को और रिच बना के क्या करूं. He along with 6 of his friends, they started their own social organization called S4S, Science for Society, S4S Technologies. और इन्होंने काम चालू किया है कि रूरल एरिया में जो अलग अलग महिलाएं होती है, आपको ये तो पता होगा कि फार्मर को कई बार डिस्ट्रेस सेल करना पड़ता है क्योंकि फार्मर का जो प्रोड्यूस होता है वो पेरिशेबल प्रोड्यूस है. अगर आज शाम तक आपने मेरी सब्जी नहीं खरीदी तो सब्जी खराब हो जाएगी, मैं सेव तो नहीं कर सकता. फिर शाम को जो कोई भी भाव बोल दो यार बेच देंगे, क्या करूं मैं, डिस्ट्रेस सेल. ये बंदों ने सोलर ड्रायर्स बनाए, जो सोलर ड्रायर्स बना के they started giving livelihood as well as converting that perishable produce into powders, जिसके द्वारा उसका शेल्फ लाइफ भी बढ़ेगा and they can sell it for higher price. उनकी सोलर ड्रायर टेक्नोलॉजी को जायद सस्टेनेबिलिटी प्राइज और एशडेन अवार्ड दोनों मिला. आपने कभी चिंग्स का मसाला खाया है क्या? चिंग्स के नूडल्स वगैरह खाए हैं? वो चिंग्स के मसाला में जो प्याज होता है ना, वो प्याज इनकी महिलाओं ने बनाया हुआ है. ये औरंगाबाद डिस्ट्रिक्ट में काम करते हैं. औरंगाबाद महाराष्ट्र का सेंट्रल डिस्ट्रिक्ट है. वहां की जो अलग अलग गांव की महिलाएं इनके साथ जुड़ी हुई है वो ये बनाती है. दिस वॉज दैट गर्ल, यू रिमेंबर, डॉक्टर आरती, यू रिमेंबर, जो बीजे मेडिकल में थी, जिसका तो ड्रीम था मैं तो चली अमेरिका. लेकिन जब उसने बीजे की उसकी इंटर्नशिप के दरमियान देखा कि इतना बुरा हाल पेशेंट्स का है and they are not getting good quality care, that's when she came to Nirman in search for an answer. What do I do with my medical training? All my life I thought I would be running to the US, but now I am met with an existential question. The healthcare in this country is abysmally bad. What do I do now? She came to Nirman in 2011 in the 4th batch of Nirman. She eventually became a psychiatrist, and then she decided to come and work in Gadchiroli because it so happened that she and I got married. So today, I'm extremely proud to tell you that in our entire Gadchiroli district, which is 300 kilometers long and which has got 12 lakh people, भूटान की लोक संख्या से ज्यादा लोक संख्या हमारे डिस्ट्रिक्ट में है. द एंटायर डिस्ट्रिक्ट हैज गॉट ओनली वन साइकेट्रिस्ट विच इज डॉक्टर आरती बांग. सो किसी के जीवन में इतना 180 डिग्री शिफ्ट हो सकता है. मैंने आपको बताया, मैंने मेरे बेटे का नाम क्या रखा है, अर्जुन. क्यों रखा होगा? और मेरा जो ऑफिस है ना, हमारे निर्माण प्रोग्राम का जो ऑफिस है, हमारे ऑफिस का भी नाम मैंने अर्जुन ही रखा है. इसलिए रखा है क्योंकि अर्जुन बोलने के बाद कई लोग बोलते हैं कि फोकस, एक्सलेंस, दिस दैट, विच आर ग्रेट थिंग्स विच शुड बी देयर. लेकिन मेरे हिसाब से अर्जुन इज एन एग्जाम्पल ऑफ अ यंग पर्सन. आप सबने गीता के बारे में तो सुना होगा. गीता बेसिकली क्या है कि वो कुरुक्षेत्र में जाके खड़ा हुआ और अर्जुन के पैर लटपटाने लगे. उसे लगा यार मैं क्या करूं, अपना काम कैसे करूं. तो अर्जुन को मेरी ड्यूटी क्या है, मेरा स्वधर्म क्या है. स्वधर्म का मतलब हिंदू मुस्लिम क्रिश्चियन नहीं. स्वधर्म का मतलब मेरी ड्यूटी, मैंने क्या करना चाहिए, मेरा पर्पस क्या है. यह सवाल अर्जुन को आया और कृष्ण ने जो गीता बताई अर्जुन को, वो तो जवाब है. समझ में आ रहा है? गीता ये एक जवाब है जो कृष्ण ने अर्जुन को बताया. जवाब अलग अलग लोग अलग अलग तरीके से ढूंढ सकते हैं. अपना कोई कंपल्शन नहीं है जवाब के बारे में कि ऐसे ही ढूंढो. Answers can come from variety of places, but the question is central. And the central question is, मेरा स्वधर्म क्या है, मेरा पर्पस क्या है. और भारत के सभी यूथ को यह सवाल आना चाहिए जिंदगी में. So I am not so bothered by the material achievements of my son. But I'll be very bothered if he doesn't get this existential question कि यार मेरा स्वधर्म क्या है, मैंने करना क्या चाहिए जिंदगी में. That is the real question. बाकी सब तो आते जाते रहेगा. Variety of examples. In the interest of time, I'll just skip some of these examples. एक यहाँ पे बता देना चाहिए, ये तो ठीक है आकाश, ये हमारा बिट्स वाला दोस्त है. ये एक एग्जाम्पल बता देता हूँ क्योंकि लोगों का ऐसे कभी कभी गलतफहमी होती है निर्माण के बारे में सोच के कि सब एम्स और आईआईटी इधर उधर से लोग आते हैं क्या भैया. तो पर्पस कोई सिर्फ एम्स और आईआईटी और सिर्फ मेडिकल स्टूडेंट्स और इंजीनियर्स का ठेका नहीं है. ये मेरा वन ऑफ माई क्लोजेस्ट फ्रेंड शरद, ही इज अ 12th फेल. ये ट्रेन में जो हॉकर्स होते हैं ना, बेचते हैं, भेल बेचता था. फिर ये न्यूज़पेपर बेचने लगा. न्यूज़पेपर बेचते बेचते शरद को पढ़ने की आदत लग गई. वो न्यूज़पेपर पढ़ने लगा, फिर किताबें पढ़ने लगा. फिर उसने देखा कि यार बहुत सारी अच्छी किताबें मराठी में है ही नहीं. तो ये बंदे ने 4,000 रुपये का कैपिटल लेके, कितने हजार, 4,000 रुपये का कैपिटल लेके वो बंदे ने खुद की पब्लिकेशन एजेंसी चालू की, मधुश्री पब्लिकेशन. टुडे शरद इज वन ऑफ द मोस्ट लीडिंग एंड सक्सेसफुल पब्लिशर इन मराठी. His books have sold more than 2 lakh copies, and he has translated books of so many people from across the globe, including 4 Nobel laureates. Abhijit Banerjee, Esther Duflo, Nobel Prize in Economics. Venki Ramakrishnan, Nobel Prize in Chemistry. Daniel Kahneman, Nobel Prize in Economics again. एक बंदा जो था 12वीं फेल, लेकिन उसने ये पर्पस ढूंढा कि मुझे ज़्यादा से ज़्यादा लोगों तक अच्छी किताबें पहुंचानी है. आई वॉन्ट टू स्प्रेड रीडिंग कल्चर. इवन विद दैट ही कुड डू इट. एंड आई टेल यू समथिंग, वन डे शरद सेंट मी अ फोटोग्राफ ऑन माई व्हाट्सएप, और मैंने देखा ना मेरे आँख से पानी आने लगा दोस्तों. वो फोटोग्राफ था कि जिन डैनियल काहनेमन का मैंने अभी जिक्र किया ना, प्रिंसटन यूनिवर्सिटी में पढ़ाते थे, इनको 2002 का नोबेल प्राइज़ मिला इकोनॉमिक्स का. इनकी एक बड़ी कमाल की किताब है थिंकिंग फास्ट एंड स्लो. अमेजिंग बुक, हाउ डज अवर थिंकिंग सिस्टम वर्क, इसके ऊपर की किताब है. तो वो जो फोटोग्राफ था वो बेसिकली उस कॉन्ट्रैक्ट का फोटोग्राफ था जिस कॉन्ट्रैक्ट में लिखा गया था कि थिंकिंग फास्ट एंड स्लो इस किताब के मराठी के ट्रांसलेशन के और डिस्ट्रीब्यूशन के राइट्स आर बीइंग गिवन टू मधुश्री पब्लिकेशन. और उस कागज पे एक साइड पे डैनियल काहनेमन की सिग्नेचर, नोबेल प्राइज विनर, और दूसरे साइड पे हमारे शरद आष्टेकर की सिग्नेचर थी. When I saw that, literally tears came out of my eyes because it's again an example कि when a young person gets fired up with a purpose, what can he or she do? We need this to happen in many young people's life. दोस्त कुछ हो गया है, तुम्हारे कंप्यूटर पे आ गया है, देखो कुछ, इसको दबाना पड़ेगा. यस, सो ऐसे तो बहुत सारे एग्जाम्पल्स होंगे, तो इनको जाने दीजिए. लेकिन अगर आपको भी इंटरेस्ट लगता है कि ऐसे तरीके के पर्पस को ढूंढने के लिए मुझे कुछ करना है, तो ऑब्वियसली यू आर गोइंग टू गो थ्रू दैट फ्लरिशिंग क्वेश्चनर टुडे. दैट्स फॉर यू एंड योर ओन फ्लरिशिंग, बट जस्ट दैट इज नॉट इनफ. इफ यू आर ऑल्सो इंटरेस्टेड इन बिकमिंग पार्ट ऑफ सच अ ग्रुप, then you are most welcome to go through our website. You will find a tab called selection process there. If you go through it, you will find our selection process, which basically consists of an extremely introspective application form. वो आपको हमें भर के भेजना है. Students from across the country send it. We'll do a brief interview with you, and then we'll tell you if you are selected or not. And then you can decide when and how to come. These are some of the very interesting questions. आपने ऐसे questions कभी देखे नहीं होंगे. I can promise you that. So go and have a look at the application form. And I have just mentioned here dates for the upcoming 6 workshops in upcoming 6 months. So you will get a choice कि आपको कौन से वर्कशॉप के लिए आना है. Is your choice, because depending on your curriculum, depending on your exam, whatever else you are doing, you can choose to come in any which of the workshop. There will be 60 other participants along with you coming from across the country. So if you really want to meet people like Amit, like Ojas, like Aarti, like Ashwin, like Sharad, And if you also want to be the one to find out your purpose, you are most welcome to come and become a part of Nirman. Okay, dosto? Because we truly believe that lives of the youth are not a product to be sold in the profit economy. इंजीनियरिंग कॉलेज में फाइनल ईयर आते आपने तो देखा नहीं होगा, लेकिन चर्चा से चालू हो जाती है किसको कितने का पैकेज मिला, किसको कितने का पैकेज मिला. जिसको ज़्यादा पैकेज मिला एज इफ वो बैल बहुत महान है, तो कौन से बैल के ऊपर कितने की बोली लगी. आपको भी आजकल पता होगा कि मेडिकल कॉलेज में पीजी करते वक्त नीट के रैंक्स में कौन सा रैंक वाला क्या ब्रांच लेगा ये मैटर करता है, और ब्रांच के चॉइस वैसे ही तय किए जाते हैं किसमें ज़्यादा scope hai, and by scope everybody means money. I'll again tell you, whoever has been in the medical field to earn money is stupid. Medical field is not a very good field to make shitload of money. If you really want to make shitload of money in your life, quit medical, become a software engineer, or become a finance professional, or best, go join politics. तो अगर आपको पैसा ही कमाना है कुछ भी करके, मेडिकल में बहुत ज़्यादा झिकझिक है यार, मत रहो, छोड़ दो कॉलेज. लेकिन अगर आप मेडिकल करना चाहते हो, यू नीड अ पर्पस विच इज बियॉन्ड जस्ट प्रॉफिट, जस्ट मनी. पैसा कुछ हद तक आवश्यक है जो आप आराम से कमा लोगे, बट व्हाट इज द पर्पस ऑफ योर लाइफ दैट गोज बियॉन्ड प्रॉफिट, बियॉन्ड मनी? दैट्स अ क्वेश्चन विच ईच वन ऑफ अस शुड बी आस्किंग योरसेल्फ. दैट्स द क्वेश्चन ऑफ माय स्वधर्म. आई होप you get the opportunity and the courage to follow this question. Thank you so much. I guess we're in time, so do we want to have any questions or should we stop at that? But I think they would be hungry, so questions nahi karte abhi. I think so.
Thank you, sir, for that incredibly moving and thought-provoking session. We are immensely grateful for the unique perspective you brought to our stage today. May I now invite our Cultural Secretary, Bhushan Jadhav, to kindly felicitate our esteemed speaker.
Thank you so much, sir. Ladies and gentlemen, we have reached our midday hiatus. Lunch is now being served, and we invite you all to take this time to relax and recharge.
To ensure we stay on a schedule for this afternoon session, we kindly ask you to return to your seats as soon as possible. Enjoy your meal.